very good morning to one and all. I, Dr. Karishma Jagdish, extend a warm welcome to Day 3 of DENTCON 2023. Just as the last 2 days have been, today also promises to be an exciting and educational ride. So let's dive right into it. Our first session is by Dr. Praveen Rajesh, who will talk to us about digital documentation in dentistry. To chair the session, I call onto the dais Dr. Ashwini Santosh, an associate professor in the Department of Conservative Dentistry and Endodontics in RUAS Dental College and Hospital, Bangalore. And Dr. Roshan Sagarkar, associate professor from the Department of Orthodontics, Faculty of Dental Sciences, Ramaya University of Applied Sciences. I'd like to introduce our guest speaker, Dr. Praveen Rajesh. He is a passionate endodontist who loves to practice and preach evidence-based endodontics. He has special interest in separated file retrieval and dental photography. His new patent allows manufacturing of an indigenous broken instrument retrieval device. His work on instrument retrieval was published on the cover page of Journal of Endodontics. He has been the keynote speaker at various esteemed platforms and has several publications in renowned journals. He's also a two-time winner of Clinical Excellence Award by the Indian Academy of Conservative Dentistry and Endodontics in the year 2019 and 2021. It is an honor to have you amongst us, sir. The floor is yours.
Thank you, Karishma. Thank you for that elaborate introduction. So, good morning, everyone. I want to apologize for my delay. I was spellbound by a magnificent campus and took extra few minutes wandering around here. So today we're going to talk about something that most of us don't like, documentation, clinical practice. How many of you are postgraduates here? How many of you like documentation? Okay, that's around 5% of the group. So, how many of you are undergraduates? Okay, most of you are undergrads. Have you ever documented any particular case or anything? Okay, very few, right? So, most of us don't like documentation because we think it's very difficult. I was exactly like you. So, I'll just take you through my own story. Before that, let's see what is the current state of documentation. So, basically, documentation means recording whatever you do as you do it in your daily practice. In India, do you think people document in their regular routine practice? How many percentage of the dentists do you think do this? So there are a lot of studies done on this and they found that just 20 to 30%, around 38% of the Indian dentists actually do this. Whereas in abroad, this percentage is way higher because they run the risk of litigations and they also have to claim insurance for their patients. So these are, some driving force for them to document their cases. But otherwise, most of us don't really have a willpower to document. I was similar. Initially, during my undergraduate and postgraduate days, I hated documentation, okay? I thought this was the most difficult phase in my life. Photography and all was something that was forced into me during my PG days, so I didn't like it so much. So once it was over, I thought, okay, great. My toughest phase in my life was over. And in 2014, I joined as a senior lecturer at Ambedkar Dental College. And then I realized that my paycheck wasn't even, enough to meet my own needs, forget my family's. So I had to work like an on-call consultant in the evenings. I think most of the PGs would do the same. But like every other consultant, I also faced troubles, the common troubles that every consultant faces, travel quite far and get peanuts for it or get really difficult cases that the GP, screws up and give you. So I realized that, these on-call consultations and, low-paying lecturer jobs are not working out for me. So I started aspiring big. I thought, the way for me to get out of this cycle is to go abroad. Okay, how many of you are planning to go abroad? Wow, quite a huge number, great. So I did a bit of research and I found that, Middle East was a good place to go. But then for your degree to be, recognized in the Middle East, you need to have some foreign degree. So I thought, okay, let's do the Royal College of Surgeons degree. They give a lot of affiliations and membership degrees for undergrads and postgrads. So since I already completed my MDS, I thought let me do the M-Endo RCS exam. So when I started going through my old records, I thought, okay, I had to submit 4 cases for this degree. And I thought I've done a lot of cases during my PG and I've documented some really good cases. But when I went through my records, I found that there were critical lacunae in every single case. Although I had a huge number of cases, but there were lacunae everywhere. So I ended up, documenting everything from the beginning. In fact, I had to change my practice. I had to go to a different institute just to start learning and documenting new cases. This took literally 3 years of my life. But at the end of it, I was able to document my 4 cases, and I was able to, in 2018, clear the M-Endo RCS, and I think that time I was the first Indian resident who did this. While I did this, I also ended up doing a lot of re-RCTs and instrument retrievals, and I got pretty good at it. And when I finally thought of moving out of India, my professor called me and told, why do you actually move out of India? I said, sir, I want to do really good work and I want to get paid well for it. He said, why don't you do that in India itself? And he took me to his practice. He was practicing in Pondicherry, and he was charging around 18K for a root canal at that time itself. So I was like inspired by him. I was like, okay, even we can do good root canals and charge well for our work. So in 2019, I opened my own practice in Chennai, which focused mainly on endodontics. And in 2022, recently we opened our referral center in Bangalore, where we only do endo, no GP. Now throughout this journey, what I realized was my lack of knowledge of photography during my PG days and my UG days. These are the photos that I took during my PG days. Okay. That led me to a situation where I had to waste literally 3 years of my life because I didn't know, I couldn't get good cases to present in an international forum. So with a little bit of investment in time and energy, not even money, even with simple photographic equipment, we'll be able to take good photographs like these. And these kind of good photographs you might think are only for people who speak on stage like this, or it's only for academicians. Of course, it does help in academics. We have written 2 textbooks on photography, chapters in 2 textbooks. However, if you look at the bigger goal, how many of you have a practice or are planning to put up a practice after your course? Okay, about 25. Rest of you, no practice? Okay, somewhere down the line, I'm pretty sure most of you are going to do practice. Do you know what is one important factor in your clinic which determines how successful your practice is going to be? Okay, these are called key performance indicators, and one of the main key performance indicators is called case acceptance rate. Anybody's heard of this? No? Okay, see, it basically tells you how many of your patients are actually going to accept more than 80% of your treatment plan. Say if a patient comes to you for a pain on the premolar, you know you're going to do a root canal. But what about orthodontics? What about scaling? What about the pit and fissure sealants? Is he going to get the entire thing done? So that's called case acceptance rate. And they found that if your practice has at least 80% case acceptance rate, you're going to run a successful practice. They found in the US that not even 30% of them were actually reaching 80% case acceptance rate. That was a pretty low number. But they found that just by incorporating one little skill, that is case presentation with photographs, they were able to increase that case acceptance rate to nearly 90%. So most of the practitioners were able to upgrade their case acceptance by doing this. How does this work? Because human beings are very visual animals. We don't like to be told, we like to see things. So I'm going to give you some small stories. All these happened in my own practice. This was a patient who thought he doesn't need a class 1 or a pit and fissure sealant. He said, doc, I'm fine, why should I get this restored? Then when we took a close-up image, showed him in a large screen, he was like, okay, I think I've got a cavity there. Same thing here, class 2 fracture GIC restoration. Patient said, I spent around $800 to do this. Now you're telling me to do an inlay for this, which costs around 5 to 8,000. He was not ready for it. We showed him some pre-op, post-op pics, and then we were able to convince him for an inlay. How many of you can recognize what this is? Can anyone tell me what this is? In the first outlook, it looks like a class 2 cavity, right? Can you make out this center port, the line on the mesial wall here? A small, sorry, it's not working. Okay, so basically that little line there, that shows that there could be a cracked tooth. It could be a fracture, probably an incipient or a green stick fracture. And the patient had severe pain. He went around 3 clinics and nobody could find it. Okay, we were able to find it thanks to photography. We were able to take a picture and zoom it in and show it to him. And as we started the root canal, we were able to show him how deep the crack was going. So patient gained trust in us. Another side of the story is when patients want to save teeth, and then you know it cannot be saved. There is a vertical root. Can you see what that is? The entire palatal segment of the tooth is actually moving, right? So this is a typical vertical root fracture, and we cannot save these kind of teeth. So we advised him to extract it. So it's our duty to educate the patient and share responsibility with him, especially when patients who are not so educated comes to you. This patient, can anyone guess what this condition is? PGs, endo-PGs here? Where are the endo-PGs? No endo-PGs? Okay. So there's a groove on the palatal aspect of a lateral incisor. What is that? It's a palato-gingival groove, right? So we couldn't explain this to the patient. We had to show it to him that, you can see a big rod is going behind your tooth. You need a surgery. Only then we were able to convince him. Here was a patient who recently came to my practice. The root canals looked pretty fine, but then just one of the root canals had tenderness on percussion. Well, I actually didn't know why it was happening, so I told the patient, see, I don't know what's happening, but I'll show you step by step of what I am going to do, and let's see, where the issue lies. So when I did a perio probing around the tooth, I found that, he had a deep 7 mm pocket only at one spot at the palatal aspect of the tooth. Can you guess what it could be? You guys didn't have a breakfast? Why so serious? You hungry? Any guesses? If there's a single deep probing pocket, what do you think it could be? None? It wasn't a fracture. Anything other than a fracture? Yeah, fracture is what I thought as well. And I told the patient, it could be a fracture. I might have to, extract the tooth down as I'm doing the treatment. But
endo.
Sorry, sir.
Primary endo. Endo-perio, but primary.
Yes, you're right. It's primary endo, but we still didn't know why it was happening because the obturation looked good and there was no significant periapical lesion as well. So we started the RUAS, just to hope. Just in a hope that we don't find the fracture. But then we found something else. After I removed the GP, now can you see what that could be? It was a perforation at the lateral wall. It was a strip perforation. I don't know how the general dentist was able to manage to do this, but probably inadvertent use of GG drills or piezo. So we found the perforation and we sealed it with MTA and we were able to redo the obturation and the patient was happy. Another case, like most of us, we get patients for one particular treatment, but then we end up doing something else. For example, in this case, we had a referred case for instrument retrieval. We had given the patient a quotation for instrument retrieval. But after doing it, after starting the re-root canal, I realized that there was can you see the red spot over there? What could that be? Again, another perforation on the floor. But you're going to spend extra time, extra money with the MTA. You have to bill the patient accordingly, right? So we are in an age where we're not doing charity in our practice. We have to bill accordingly. So we have to itemize. We have to show to the patient there's an additional procedure that you need, and we'll be doing it, and we will be billing you. How many times when you see a class 2, you're so excited that you start excavating the caries and you find there's an adjacent. Even in the adjacent tooth there's a cavity, right? So these are called approximal lesions, and this happens quite often, and we can't say patient, pay 2,500 for a class 2 and then now I'm doing 2, so pay 5,000. He's not going to believe you. He's like, I came for one filling, why are you doing 2? So we have to show to the patient, we have to itemize our treatment plan. This happens very often when you remove old restorations, crowns, you find a lot of adjacent decay. Here was a case where my friend himself did this root canal. He said, I didn't miss any canal, I'm pretty sure it's fine. But then I said, see, there is another canal. He still didn't believe, even when I showed the x-ray. So I had to actually take pictures and show him, there was an adjacent canal which you actually missed. So photographs help you in educating patients as well as doctors. So photographic records can be of two types, standard and strategic. Standard means for any patient that walks into your clinic, you take these set of photos. Usually we take maxillary and mandibular occlusal and a frontal view. Okay, and strategic means you're going to take pictures which are pertinent to that particular case. Okay. For example, so for standard photographs, I usually use a DSLR, and for the strategic pictures, we use our microscope, or sometimes we can use a DSLR as well. Now, standard set, like I told you, you need to shoot maxillary and mandibular occlusals, and usually, you find things that you don't even see with your naked eye or in your clinical examination. And even in your frontal view, sometimes you see things that you can't see. A cervical abrasion, sometimes it could be a buccal caries that we miss out during our examination. All these things can be made out only if you take a good quality image. I understand that most of you use cell phones to take images. Even those are good enough, provided you use the proper retractor, mirrors and everything, right? So we all know this, right? For whenever you work on an interdisciplinary case like a smile design or something, digital smile designing, you have to take good photographs because you work with a lot of dentists, not just this. You have to work with your lab, you have to work with your technician, with your prosthodontist and everything, because we need to get it right for us to get the right emotions. And in fact, when we did the mock-up for this patient, he was so happy that we closed his diastema that he literally had tears in his eyes. So again, we need a standard set of photographs for digital smile designing, for orthodontics, different things, right? Okay. A very important reason why we photograph is also to save ourselves. Now, a lot of us have not entered into clinical practice, but once you're into clinical practice and you spend 5 to 10 years in it, you'll realize a lot of patients come in with complaints with your previous treatments. For example, we did a non-wet bleaching for this case, and after the ortho, the patient came and said, doc, you didn't do the bleaching at all. The tooth is still discolored. We said, ma'am, there was a lot of blame game going on. We said, absolutely no, we did it, and I can show you proof. So luckily we had proof. We had pictures taken with a shade guide. We were able to show her that we did correct the color, but not to the extent of maybe what you actually desire. So we did another round of bleaching. But we charged her for it, and patients still had trust in us. So the name of the game is trust. Okay. In fact, nowadays we have a lot of litigation issues as well, especially if you're treating patients who are either lawyers or have good lawyers in their family. Be careful. So here's another patient where we told her to do an RCT for the lateral incisor, which made sense, but patient said she didn't want to do the root canal, she wants to try a filling. So we recorded the entire thing. We showed her that we're literally placing something on the pulp, on the nerve. We don't know how it's going to react, but luckily till date she didn't have any trouble with it. So sometimes the patient's also right. Here was another case which we had treated sometime in 2020, and this patient came back to me in 2022, 2 years later. And we had done a lot of crowns for him, and he brought 2 of his crowns in his hand. So I was like, oh, did my crown just come off? So we just for our information, we went through his old records. So this is where old records help you. So this was the current picture, and this was a picture taken 2 years back. So as you can see, the area where the crown had actually come off actually had an old crown. So basically it means that I didn't do those crowns. So we were able to safeguard ourselves because patient was absolutely convinced that I did those crowns. Okay, so situation like this can happen, and we were able to convince him that these were not the crown that we did. It was there before we started. As you can see, we treated this first molar on. Actually, he had all the first molars which we did crowns for. So we went ahead and showed him, and then we were able to convince him to get all the even the two dislodged crowns which had come off. We redid those. We redid the RCT for him, and then So basically, we got the trust back. I'm pretty sure that if I didn't have these old photos, the patient might not have come back to me. Also, here's a very peculiar case where the doctor, after we removed the instrument for him, actually felt we didn't do it. So luckily, we take pictures of all the stages in the root canal when we do re-root canal and remove everything. So after which we were able to convince him. So looking at all this, IDA themselves have given a rule saying that whenever you are having a private practice, it's mandatory for you to store the images, the records of radiographs, the photographs, and the diagnostic data, all of them for at least 8 years. Okay, so this is actually a rule, and there can be legal consequences if you don't do it. And of course treatment. So these are the records that you need to keep in your dental practice. I know most of us don't do it, but when there is one issue that occurs in our clinic, we realize how important it is. Okay, coming back to why documentation is still important is because I want to maintain my shade record. Usually whenever we give a crown in my UG days, my PG days, I used to do a lot of cast post restorations. And I used to like doing them. I felt my work was good. But then my lab guy used to give me crowns like this. So I used to be livid at him. But at that time, I didn't know that, the number one reason for lab remakes and poor crown selection was not the lab technician, but it was you. Because we feel just by telling him A1 or A2 or A3, he's going to get it right. But that poor fellow doesn't see all this. He actually sees just this, right? He just sees the cast. There could be so many other factors within the tooth, like the chroma, the translucency, and etc., which we don't communicate that well. So what we do is we take shade tab pictures, at least 3 shade tabs, and we take it and we edit it a bit. We increase the contrast, decrease the value, and we completely desaturate one image. And we send all these 3 images to the lab, and they usually get it right. For example, this patient had to go to France in a week's time, and we had to get his veneer right. It was a single tooth veneer. It's extremely difficult to get it right, but thanks to these photographs, the dental care guy was able to do it quite well. Another method that we can use is called cross polarization, where we just how we use polarized sunglasses. We can add these glasses to our camera, and we can eliminate the reflections, so you get a better shade communication. Another tool we can use is Photoshop, where we can get the exact lab values. Anybody's heard of lab values? LAB? No? L stands for? Yeah. So L stands for what? L stands for the value, right? Value, and A and B stands for chroma. So you get it instantly by putting it on Photoshop, and you see which lab value corresponds to the shade tab accurately. So you're making a subjective work into an objective work. Again, we communicate, especially when you send work to a different state where they don't understand your language. My Malayalam is very bad. So the dental care guy wants me to send all photographs. So we take pictures, we annotate, and we tell them, I need these corrections, and he does it. So annotation is a big tool whenever you do these kind of work. Another reason why we photograph and document is you can analyze your own work, what works and what doesn't work. If you see your treatment is doing quite well, good. When you know it's failing, for example, that had a pretty good lesion healing. This case, I did a ceramic inlay. It dislodged within 3 months, and then I rectified my tooth preparation and everything. Then I did a simple composite restoration, and that stayed on for like 2 years. So you learn from your own mistakes. Another reason why we document is if you want to educate people. So we used to take a lot of micro-endo workshops in Chennai, and a lot of participants used to ask me, Doc, why should I actually use microscope after access preparation? Because I can't really see the canal underneath it, right? So we had to show them that, microscope is useful for checking the working length during preparation, to see the level of rotary file activity, to see exactly if the rotary file is cutting the middle, apical, third, or whatever, just to, fine tune your preparation. Another reason is to see whether your irrigants are actually working, whether your irrigation is actually bringing out some debris, or is it looking, cloudy or clear. And when you're activating your irrigant, what kind of solution, what is the change in the color, or is any blood coming out to, you might be over irrigating that scenario. So basically to educate people, your photographs can educate a lot of people around. In today's day and age, how many of you actually follow Instagram influencers, dentists? Okay, why do you actually follow them? Is it because they look good or because their work looks good? Their work looks good, right? So, as a dentist, it's your duty to start influencing others. Because everyone has their own unique talent, your own unique niche, and you have to bring it out to the world, right? So you start documenting your work so that you can become an influencer 5 years down the lane. So also show to your patients, show your case album and everything to your patient. It takes you a long way. In fact, my first job in my in Ambedkar Dental College in 2014 was because of my case album. At least I believe that's so, because 7 people applied for the same position and I got it. So I think most of it. Okay. So all of you can land excellent jobs if you have a good portfolio. That's what I'm trying to say. Even now, I make my own portfolio with my cases. So this was a portfolio I did in 2017, because every year you keep doing new cases, right? Keep documenting. And if you want to present in great forums like these, you have to build yourself. In fact, talking about case portfolios, I've gone as a visiting staff for Savita a couple of times, and I found that even undergraduates have a case portfolio. They have this thick book of case portfolio. And you can imagine the PGs. The PGs have double the size. So they basically document everything. It doesn't matter what you do until you actually document what you've done. And if you are interested to present publish in any good international journal, like this is the IEJ's guideline, they want extremely high quality images which are at least 300 DPI. 300 DPI is just it's something to tell you that, even if you print, the quality will not go down. And that can be got only with DSLRs, unfortunately. The pictures that you take with mobile phones usually come up to 144 DPI. But I don't know, maybe in the future the mobile phones would upgrade themselves, but as of now it's like this. So like I told you, when I tried to give my M.Endo exams in the Royal College of Surgeons, Edinburgh, they wanted me to present 4 cases, and like I told you, I didn't find those 4 cases. I had to re-record all of them right from the beginning, and I was able to clear them in 2018. But I spent a lot of time for that. So if anyone's interested to do the AACD or any of the accreditations, international accreditations, I would really recommend you to start working on it from day one. Because AACD has a very set, clear guidelines on what you need. So this is just to show you what I recorded as a PG. I had so many cases. I had segregated it according to each treatment that I did, and I had to. I just had to give them 2 good endo and 2 resto cases. I couldn't do it, right? Because I didn't document it systematically. So what we do nowadays is, after we document, we also make a small case report, and if it's a referred doctor, we usually send this case report to them instead of showing the entire video and cases that we have recorded. We make a small case history like this, and we give it to the doctor so that when we understand what we should have done better in this case. So since we do a lot of referral relationships, most doctors don't like to refer their patients to a different clinic because they feel the doctor is not transparent or clear enough with them that they're going to do a particular treatment. So we believe that sharing your treatment notes and your photographs really helps in transparency. Okay, so I hope I have made it clear why documentation in photography is important. Can you guys tell me what are the important goals of photography, one by one? First, you want to? Patient education, perfect, great. Then you want to communicate with your fellow colleagues. Then you want to communicate with the lab. Then you want to maintain your records, where it could be because of legal concerns or anything else. Then you want to communicate, what you've learned to the world. So educate people. Then you want to, it can even help you in marketing your practice and doing presentations like this. So how many of you want to learn documentation, photography? Oh, great. I was able to convince you guys. Good. So today we don't have time to show exactly how we do it, but I'll give you a gist of what we do, just 2 more minutes. So nothing is possible without this golden word called team effort. This is my team in Chennai, and to be honest with you, for the last few months, I haven't taken any standard set of photographs. All that I do is take strategic photographs. So I've trained everybody in this team, except my receptionist, knows how to take a good photograph using a DSLR, using twin flash, not even ring flash. So this is how my assistants take photographs even before I go and see the patient. So they take the photographs, all the basic demographic details and the basic clinical findings are recorded by my assistant doctor, and then we finally, all that I have to do, so they take the standard set, I have to go and look at it and present to the patient like a case report, and then maybe I'll take a few more strategic pictures, and then I'll be able to, give them a more detailed insight of what's going on after my detailed clinical examination, more specific examination, that is. And I'll be dictating the clinical notes and the treatment plan to the patient. Right, so this is how our case records look. So I understand that it's not possible to sit in a busy practice. It's very difficult to sit and type everything and stuff, right? So we have one person doing each of this. Say, for example, the demographics is entered by my receptionist. The basic clinical findings is entered by my assistant doctor, and I enter the specifics of treatment plan. Okay, so just to brief you on the workflow, how we do it. First, we register the patient in the front desk. So this will be useful if you guys open up a practice in the future. Then my front desk gives the the registration form. From the registration form, she fills the demographic details in my patient management software. So I would recommend everybody to get a online patient management software. And don't use pages and pages of stuff. Don't give patient files to take it back. It doesn't work nowadays. And ask your assistant doctor to record the vital information, especially the medical history, because you don't want to go wrong there. You don't want to have a medical emergency in your clinic. So be careful there. Ask your either assistant or your doctor to take the standard set of photographs. After they have done with the photographs, you as a specialist can come in, take the brief history, and then start with the detailed examinations and strategic photographs if required, followed by, after the treatment plan and everything is done, you ask your doctor to enter all the details. Within 24 hours, you should ask your doctor to enter all these details and put the photographs in the patient's folder. Okay, from the patient's folder, put it in the patient management software. So there's a very important reason why we have to go through this particular flow, because if they miss anything, you might lose data. Okay, imagine if I had lost one pre-op photo of that patient who lost his crown, right? It's just invaluable. After which my assistant doctor would do it, and then what we do is we usually share all these digital records with our patients and with our doctors as well, the referring doctors. So there's a lot of transparency everywhere, right? So that brings us to the end of our presentation. This is our practice in Chennai. So if anyone's interested to see how we do most of our work, you're all welcome. So in Bangalore, we are located at Tubrali, Whitefield. We also practice sedation dentistry, especially it's very useful while you do root canals under the rubber dam. There are many reasons for why it's important. I'll explain to you guys if we have time later on. We have a Facebook page called Microsmiles where we teach evidence-based dentistry. A lot of clinical tips on restorative and endodontics is there. You guys can visit if you guys have the time. We also run a Insta page called Microsmiles, or you can follow my page, Praveen Do It. We give a lot of tips for people who are preparing for their royal exam, the royal college exams like MFDS or M-Endo, MRC, your M-Perio and M-Ortho as of now. Of course, like I told you, we do a lot of micro-endo workshops as well, and we have our own instrument retrieval kit which we have been teaching to in a small way. We haven't come up with a big way, but we are doing this for a few endodontists, and our course happens predominantly in Chennai and Coimbatore. It happens twice a year. So thank you for your patient listening. I would like to dedicate this presentation to my grandmother who is no longer with me. I'm here because of her. She always tells me to teach as much as you can, because even till the age of 70 she used to teach clay modeling to little children in her place. So if one of you have got inspired today and start taking good photos and document your cases, I'll be really happy. Thank you all for wonderful.
Thank you, sir, for such an engrossing talk and reinforcing the importance of documentation. Clearly, your passion has ignited a spark in our budding dentists. Do we have any questions from the audience?
Very shy audience.
I request our chairpersons to share their views on the talk.
I always wondered till how many years we have to store the records. Today, I think it's clear.
Thank you, sir. Actually, when I realized it, when I was preparing for the presentation, it's actually a rule.
Initially, I thought it was only for 5 years.
But yeah, this was an article from IDA.
Yes.
This was a very impressive and energetic presentation.
Thank you, ma'am.
I think most of them are like definitely going to follow.
I hope.
Workflow was very impressive.
Thank you.
Just want to ask you if they come mirrorless cameras.
Mirrorless cameras, yeah, in fact, so we, since 2014 to now, just like a year back, we were using DSLRs and we were quite comfortable with it. But mirrorless give you that advantage of, focusing in manual mode more easily. So if at all you're a person who wants to take at the right magnification ratio in a manual mode, mirrorless is the way to go. Otherwise, regular DSLRs take equally good images. In fact, we liked our earlier setup better because it's a little more lighter. The new Sony mirrorless is a little heavier because the lens itself is very heavy. So if anyone wants to buy a camera, I would recommend a basic Nikon D3500. It will cost around 30 to 40K. And a 85mm macro lens, which will again cost around 30 to 40K. And a simple Godox ring flash, which will be around 10K. So it will work up to 70 to 80K.
So much. Now request our chairpersons to present our guest speaker with a token of appreciation.
Yeah. Thank you so much. Thank you. Thank you, sir. Thank you.
I request Dr. Kranti to kindly present a certificate of appreciation to our guest chairpersons, Dr. Ashwini and Dr. Roshan. Thank you, sir. In today's demanding world, it's not always easy to satisfy your patient's needs. Function is important, yes, but aesthetics is equally important. To shed more light on this, I'm pleased to welcome our next guest speaker, Dr. T.V. Narayan, who is with us here to talk on the topic Aesthetics and Implant Dentistry, the what ifs and wherefores. The chairpersons for the session are Dr. Prabhuji MLV, Professor and Head, Department of Periodontics at Krishna Devaraya College of Dental Sciences in Bangalore, and Dr. Ranganath K, Professor and Head, Department of Oral and Maxillofacial Surgery, Faculty of Dental Sciences, Ramaya University of Applied Sciences. I request you to please grace this dais. He was also adjudged Best Outgoing Student in Karnataka that year. In All India GET ranking, he is ranked an inevitable 34th. He did his post-graduation in oral pathology from Nair Hospital Dental College, Mumbai in 1996 and started his practice in 1999. He's trained in implant dentistry in Berlin, Seoul, and Germany. He is a fellow and diplomat of a prestigious International Congress of Oral Implantologists. He is also the founder director of International Team of Implantology. He has been a distinguished speaker at national and international conferences on implantology, and his papers on oral pathology and implantology have been extinguishedly published in national and international journals. Sir is also the key opinion leader for 3M Novabone products, and his focus has remained on practice on implants, aesthetic dentistry, and full mouth rehabilitation. So please put your hands together to welcome Dr. T.V. Narayan, sir.
It's indeed a pleasure to be here amongst you all, and I would really like to extend my gratitude to Dr. Sindhu Matthew for the invitation. We go back a very long way, and I mean, it's a great pleasure to have met someone that, I get that it's not. Right, so I'm going to get down to business because we don't have much time to go through with this. But in the next 30 minutes or so that I'm going to speak to you, what you're seeing over here are cases with at least one or two or more implant restorations in each one of these photographs. And I must congratulate Praveen for that fantastic presentation. And it was inspirational for me to listen to him, and I hope that you will go back with some inspiration from that. But what I want you to see over here is that each one of these cases came to me for an aesthetic replacement of a tooth that was failing or had already failed. And what we need to understand is that from a point of being a completely surgically driven discipline, to that point in time, about 15-20 years ago, when we considered it a restoratively driven principle, I think we are at the age when we have to understand that implant dentistry is an aesthetically driven principle more than anything else. So when you have a patient who comes to you looking for a replacement, they are not looking for a piece of chalk in their mouth. They are looking for something that appears like a tooth and behaves as close to a tooth as possible. So apart from this restoring function, aesthetics is of prime importance in our day-to-day implant practice. Typically, when I have short presentations, I like to put my conclusions out first, so that I don't miss out on this at the end of the presentation in case I don't complete. So before we go to anything else, I need you to understand that implant therapy in the aesthetic areas is a very complex phenomenon. It's not a straightforward. The minute there is display in the smile, that becomes your responsibility to take that much more effort to try to finish that case well. And long-term implant health and aesthetics is predicated on you being able to provide the right kind of environment over there. And that environment is what we know as the peri-implant phenotype. So you have to develop that. I know many of you are postgrads, most of you are postgrads, and many of these words may seem a little, may seem bigger than they actually are. They're just simple things that you're actually learning on a day-to-day basis. Just about you going back to your patients and applying to those patients what you hear and learn over the. So the first step that you will take is assessing risk. Right? That means that you have to know what can go wrong. If you do not know what can go wrong, there is no way that you can ensure that things go wrong. So the whole idea of risk assessment is to know what are the things that can lead to failure. And failure doesn't mean a screw falling out. Screw falling out is nothing. Failure means failure also means that you're having a screw over there which is satisfying all those needs for that patient. That means aesthetically, functionally, and in form, and all of those aspects, it is doing the job that it is supposed to. So for me, if there is a patient who comes into my office and there is something that's in the aesthetic area and there is no display in the smile, it's not like I'm going to treat that case any differently from the one that walks in with that very high aesthetic expectation and high aesthetic show, right? Because if you're going to do this for every single case, you practice this on those cases which do not need that much attention. You will find that the one case that comes in demands to look like Aishwarya Rai in your office, you have the skills more enough to be able to deliver, right? And also by then you also develop a thought process and an algorithm for yourself as to what works in your hands. Everybody has a different set of skills with with different kinds of techniques. He can retrieve instruments beautifully. For me, there are some other things that for me, the best thing that I can do is work under a microscope to make diagnosis. So there are different things that all of us do. All of us have our own. So it's necessary for you to find your center and say, okay, this is my sweet spot, right? So that happens only when you practice the same thing over and over again to try to get the right outcomes. And in all of this, there is one aspect of implant dentistry that you cannot negotiate at all. That is where you put your implant. Okay? That is where the whole crux of the matter lies. If you mess up with implant position, particularly in the aesthetic area, you can be sure that you will not get the desired outcomes. So that's where you need to start to now apply those things so it's not enough that you've done 10,000 implants. And so I've done 10,000 implants, putting in a screw in the right place is no big deal for me. If you have something available at your fingertip, at your disposal now, which will ensure that you do not have even the slightest mistake in implant placement, by all means go ahead and use it, right? And that's the reason why more and more I'm adopting guided surgery, because it's something that is available to us. It's something that we can make the best use of for delivering to our patients, and it is not as inaccessible as it was some time ago. All right. So the learning objectives here is for you to understand what the peri-implant phenotype is. You will understand, or I will at least touch upon the key determinants of aesthetic risk, and I will try to give you an algorithm of risk assessment on the basis of when you place your implant, whether you place your implant the day you remove the tooth, or you place it sometime later, and a little bit of how to think about hard and soft tissue enhancement, and then using multidisciplinary approaches to achieving final outcomes. All right? So the peri-implant phenotype is basically just two things, the hard and soft tissue around the implant. But how do you make assessment of this peri-implant phenotype? So you want, or what is the impact of this peri-implant phenotype on long-term implant aesthetic success? And I've just tried to collate all the evidence that we have over the last few decades into this one slide to tell you that these are the three things that you need, right? You need a healthy bone of greater than 2 millimeters on the facial aspect of your implant. You need to have at least 3 millimeters of vertical attached soft tissue from the from the platform of the implant to the marginal tissues. And you need to have a zone of attached keratinized gingiva. And that attached keratinized gingiva is apart from this tissue that is vertically on top of the implant platform. It has to be on the lateral aspect of the ridge. So when you put all this together, we have this publication from 2019. Again, this is from Wong's group, which talks about the peri-implant phenotype and these numbers that we just ascribed. And the same thing that I just spoke about, the soft tissue height, the peri-implant. So this is just, again, a summarization of all those, all that research that has gone into understanding this over the last few decades, right? So we want to have thick mucosal thickness that is greater than 3 millimeters. 2 millimeters is the bare minimum. You want to have a soft tissue height of, again, 3 millimeters and peri-implant bone thickness of 2 millimeters and more. If you have this, you can be sure that all this will stay stable. It's all about stability, right? So this will stay stable for a long period of time, and then you can enjoy the aesthetic success that you're looking for. So if you just translate this to a clinical image like this, like he was telling you about strategic images, this is as strategic as it gets. You focus on what you want to look at, and you'll see that we have a soft tissue height which is about 3 millimeters, mucosal thickness of about 2 millimeters. When you look at attached tissue over here, you want to have a minimum of a zone of 2 millimeters of attached tissue. So just remember that there is a sulcus, and all this tissue that is, though it is keratinized, is not attached. All keratinized tissue is not attached, right? This is free tissue because there is sulcus on the other side, right? The attached tissue is this zone. So you must try to achieve this zone of at least 2 millimeters of attached gingiva. And of course, the peri-implant bone thickness on a case like this, you can see the amount of bone we have on both sides. It's well in excess of 2 millimeters. So you do all the procedures that you need to regenerate to get this tissue if you need. Okay? So in this particular case, all this is regenerated bone on the facial of the implant. Right? And it is not a bone-like tissue, it is regenerated bone. So you have to learn to do those procedures to get there. The determinants of aesthetic risk start with your patient expectations. Half the time we are not listening to what our patient is trying to tell us. So if you start to understand what your patient is expecting from you, right? If you have somebody who walks into your office with with very, very ridiculous expectations, and there are lots of them who come like that, who come with terrible dentition, with no maintenance over so many years, and suddenly they all want to look like, Cindy Crawford. Cindy Crawford is my time. Maybe these days it's somebody else. But they all want to look like somebody else. And if that sort of an expectation is what your patient comes with, and you are not in a position to deliver, send that patient off to somebody else. Don't try to treat that patient yourself. So it's very important to understand that expectation, to also know what is in your capacity to deliver. If you do not have the skills to deliver, then call somebody in to do that, refer out, whatever it takes to get the right. You'll find that works a lot better for you in terms of acceptance rates as well, because it's good to be honest and sincere about what you're doing. So one of the big determinants is the smile line, right? How much display is there? So if you have somebody who has a lot of display, then you know that your treatment is that much more critical. What you do for that patient now becomes it's a totally different ball game. If you are not, the transition line of your restoration finally, if it's going to show in such a manner that you do not have an aesthetic outcome, then you have a problem, because your patient has come to you looking for aesthetics. So assess that very well to start with. Make sure that you know how much display is there, where is the line of transition of your prosthesis going line, right? And do you need to incorporate any other pink material or whatever to cover that, to get to that, to finish that restoration off? Will you be able to match that with your neighboring pink, right? Because one of the biggest things that we have in implant, the biggest problems we have in prosthetic dentistry of any nature in the aesthetic areas is not in getting white aesthetics. It's always about getting pink aesthetics. Pink is as important or more important a component of the aesthetics as the white is. Getting teeth color shades to match is not a big deal. But when you are trying to match shade to gingiva, which can change shade and lots of things happen, and you have something that is an ugly pink in front, it can be a big deal. Okay, so before you start doing anything else, and like I said, you now have to look at how many teeth are to be replaced, where you want to put the implants for that, and where is the interdental height of bone, right? Because the interdental height of bone will dictate whether you get a patella or not. And if you have patella in display, you do not have the IHB in the right place, then you can expect that you will have black triangles over there. Right? Apart from this, like I said right in the beginning, 3D implant position, if you do not get that right, you will have a problem. Right? Look at how much hard tissue is there, where did the IHB lie, would you need to do additional procedures to get more hard tissue if the soft tissue volume is adequate and keratinized tissue is adequate or not. And so I'll just talk you through a couple of cases where this display makes the case what it is, right? And so just before I do that, let me also tell you about my clinical algorithm, how I assess a patient who walks in before I start doing anything else, right? And then I will, this algorithm is based on when I'm going to place the implant. If I'm looking at doing an immediate implant placement or an early placement, which is 6 to 8 weeks after extraction, or the patient has already lost a tooth and come to me for a replacement now. Now, all these three are different scenarios. In my office, in my practice, I find that I am able to develop best aesthetics when I have from the minute the patient enters before the tooth has been removed. That's what works best in my hands. Because practically 95% of the time when I'm taking a tooth out, I'm putting an implant in. I guess I've practiced it enough number of times to get that right. I find that doing it early, I can develop the same aesthetics, but I have to work a lot harder. And I have to work the hardest when somebody else has done the extraction, probably at another point in time when the philosophies were different, where there's so much hard and soft tissue lost, that I need to reconstruct a lot more to get to where I want. Right? So you'll see me touching upon a few cases like this to show you what I'm talking about. And you'll see also that there are the same sort of theme repeating itself, starting with how much display, to the condition of the tissues, to the interdental height of bone, and what lies next to that tooth, if you have restorations or a natural tooth. And how do you plan to put a provisional? You take a tooth out, put an implant, don't put an implant, but you take a front tooth out and send your patient off without a provisional, you can expect that you don't get that patient back into your office. If they are not willing to walk out without a tooth in front, right? So you need to make a plan for a provisional and a perfect provisional each time. All right, so let's look at a case where there is huge amount of gingival display, right? This is something that Dr. Sinju and I worked together on, and I must say that this is one of the most satisfying sort of patients that you can see or you can treat when you look at what you can get up to. So you can see that he's got crazy amounts of display. Tissue display along with the positions of teeth are periodontically compromised. There's a whole lot of things going on, right? And this is where you need to put your thinking hats on. It's not just about saying, oh, these teeth need to go, right? You take the teeth out and then do what? Then you are staring at something, a canvas which has already got splotches on it, and you are now trying to paint around all those splotches, right? So you now need to start thinking about what can I do with this patient, which can get me the best out of the case. So we involve our other colleagues. Sometimes against, we have this debate then, right? Are these teeth going to hold up with orthodontics, especially with the amount of periodontal tissue loss? When you need to be convincing in your arguments as well, both sides. Many a time you find that even with cases like this, you can get alignment. Once you get alignment, you get the planes into position, then you find that a lot of things that started off looking like a disaster are now so much easier for you to handle. So once we get the alignment, we've got our planes corrected, now we are ready to go ahead and place implants because those teeth still need to go. And like I said, I might have done this 10,000 times, but every time I'm not sure, there are so many variables, right? You go back, that day you had a drink too many the last night, or you woke up in the middle of the night with a crick in your neck, and then you're going in to perform surgery. You cannot always be optimal, right? So it's always good to make use of the available technology. So we go guided with this case. We plan where we are putting our implants and execute to the teeth as to what we were planning to do. Now in this case, I extracted those teeth. Those teeth are now my bone graft material. So I will put this to a grinder and convert it into a dentin graft, which will be used once I place these implants. And we go guided to get the implants in the exact position that we want. Again, three-dimensional positioning is absolutely non-negotiable. Once you get it in the right place, you get a provisional made, which is made out of PMMA. So if you remember where we started, right? If you remember the images that I showed you where we started, to where we've come now, the display is considerably reduced. This is one case where display was so excessive that I had to reduce display, move the transition line up without actually cutting bone off to move the transition line up, right? So we moved the teeth into a better place and moved the tissue and bone into a better place to get the transition right. Once we've allowed the tissues to condition with that perfectly designed provisional, we are now ready to place our final restoration. And that's what we get back in this scenario. It's a post-infused to metal bridge. When we finish, you remember where we started? With everything flared and all over the place. We'll be finishing this case with a much more pleasant smile and outcome than where we began. This is another case with a similar problem, but a different approach to the same problem, right? We have a lot of display. We have a 40-year-old woman with a lot of recession. She's lost the interadental height of bone. In that case, we had excess. Here we have deficiency. But when you look at the display in the smile, there is still a lot of display. She's already got those black triangles. When I extract these teeth, which are now mobile and they just need to go, they've been treated periodontally, lots of things have been done to them. But when I extract these teeth, I know that I'm going to lose much more bone. But when you take this, and this is the importance of photographs, as Praveen was saying, when you look at this photograph, you'll see that I have a lot of display all the way to the first molar of gingiva, right? So if I can't match the pin, then I don't have, there is no way that I can get her aesthetic issue sorted. And her prime concern when she comes to me is for aesthetics, okay? So we need to now look at a different approach from what was done with the other case, where we pushed everything up and moved everything around. Here, orthodontics was employed by Dr. Sridevi at that point in time to move the teeth and the tissue down, because I want to get tissue down. I want to bring the gums down. So we move the teeth down to finish the case with all those black triangles closed, to finish the case with the gingival zeniths in the ideal position, as opposed to this reverse architecture that we had to start with. So a patient that walks in like that and walks out like this, albeit after 1.5 years or so of therapy, it's worth the effort, because after 10 years, this is what she looks like. 10 years, if I can have a patient looking like this at the end of 10 years, and the tissues around my implant restoration looking like this at the end of 10 years, that's the other importance of documentation, because you get to see how your treatment holds up over time. Sometimes that experience is much more than what is published evidence. Okay? Sometimes that experience, and I mean, if you go back into what the definition of evidence-based medicine or dentistry is, it is always the judicious use of the available evidence. That means that you do not only read what is in the book, you use your brains to see what will work for that patient at that point in time. All right. On the other hand, when you have, now this is an almost 80-year-old, 76-year-old woman, right? She comes to me with a problem, but her display is very, very minimal. She's not at all, she's in a mess inside. There's no doubt about that. But the amount of display that we have is very minimal, right? I'm not one to take out teeth and chop bone off to just take transition lines up. But if I get a patient like this who walks in and I can finish him up like this part doesn't really matter so much in the final analysis, because as far as she's concerned, that is the smile that she's going back to. That's as much as she's going to display. At 76, she's not going to be lifting her lip to show her friends how, where this emerges. As long as I have respected the peri-implant phenotype enough to have health over there, this is all that you need to do for. So again, it depends on using this judiciously. Do I know how to get vertical bone? Yes. Do I have to do vertical bone augmentation for every patient? No. That's what you need to understand. For a 76-year-old, now she's suddenly, after all of this, suddenly she's gone on to bisphosphonates. I'm so thankful I didn't try to do anything with major bone grafting, right? So you need to start to differentiate when to do what, and that comes only when you start looking at all of these cases more holistically. At the end of 3 or 4 years of treatment, if I have an outcome like this, I am more than happy for that patient, because at 76, this is not a fixed bridge piece. They're all individual crowns in the lower, except for the lower anterior. All right. Those of you who are not familiar with this, it's a good idea to maybe even take a picture, go back and find the reference and read this up, because it tells you what you can get, how much vertical soft tissue you can get around the different kinds of restoration, different kinds of structures in the mouth. Between teeth, between a tooth and a contact, between two implants, you'll find that the least amount of vertical tissue that you get is between two implants. You can only get up to 3 to 3.5 millimeters of soft tissue between two implants. That is often not enough for having a papilla or a papilla-like structure which fills up, because we need 4 to 5 millimeters of a papilla between our anterior teeth. Right? So you need to know this to be able to decide on where to place your implants. Whether you need to put a single implant for each tooth that you're extracting in the aesthetic area, or you want to put in an implant and a contact, because you will get better tissue, better vertical tissues around contacts. As spoke about implant position being non-negotiable, and the ideal implant positions are like this. How much time do I have? Okay. The ideal implant positions should be like this, within within 2 millimeters within this tangent that you draw between the incisal edges of neighboring teeth, to ensure that the emergence of your restoration is in the right place. Right? So when you do this by default, your screw axis position on your implant starts to emerge towards the cingulum of your implant. Okay? I'm not getting into the depths of how this whole arrangement came about, but to be able to aim for this each time is a great thing. If you do not achieve this cingulum emergence each time, it is not a sin, as long as you have the peri-implant bone and soft tissue that we spoke of in adequate amounts. Okay? So when you position for success, you want to position it as deep as possible and as shallow as necessary. Okay? What you need to understand when I say this is that the further palatal you go, the deeper you will have to place to be able to get an emergence which is natural. If you are palatal and shallow, you will end up with a very flat, submergence profile of your implant restoration. So you need to go further deeper, the further palatal you go. So you need to learn to get that balance right. It works best if you do, a mock build-up, mock surgeries, and learn to place your implants in the right position each time. So if you want to get your implant restorations to emerge like this, it's difficult to tell which is the implant out here, right? It's the lateral incisor, but to get the restoration to emerge like that, you have to place your implant in the right position each time. And then, like I said, the same thing about the tech. It also pays to understand where the root lies within the bony housing. We call this the radial root position. You can always find this article in the Journal of Prosthetic Dentistry by Luckman and Rucoit. Also tells you how you can angulate your osteotomies and what sort of restoration you get over it. If you place your implant like this, you can only get a cemented restoration, right? If you place your implant like this, you can only get a cemented restoration. You can't get a screw-retained restoration. The screw axis will come out and take it. So you need to understand that based on. So let's take a look at a case with adjacent central incisors. This lady came to me with these two teeth failing. She had these crowns repeatedly coming off, then she had somebody made splinted crowns, and she had a periapical going on one of those teeth, and she was just fed up with the whole story. So I do this procedure known as the socket shield, where we leave a piece of the root behind. I've been practicing it for over a decade now, and I think that's the best way for me to get the best aesthetics possible in these areas. So I leave a shield of the root over here on both these teeth. We go ahead and place our implants in the right three-dimensional position. How? Using a surgical guide, because this is the only way I can always ensure that it is in the right place. And we finish the case like that, right? So if you remember where we started, we've ended up with a stunning outcome for two teeth which had kept failing and she was miserable. So apart from just doing that, we also managed to get a few veneers on with the other teeth to correct all the other issues that she had out here. And that's it. It was a fairly simple procedure at the end. But what went into getting to that outcome was the planning that went in here, right? Make sure that we got the implants in the right place. We did the right sort of procedures to make sure that we don't lose anything after we've taken out those teeth. And those are the two implants over there. Let me tell you at this point that Where I'm least nervous and every day I'm nervous, every time I start with my drill, I may have done 10,000 of them. Every time I start drilling, I am nervous. It's good to be nervous. Keeps you on your toes, keeps your head sharp. So least nervous is when I'm trying to put two centrals. Because I know whatever happens, that is one propeller I don't have to worry about. Because, you know why? That's the only unique propeller. There's only one propeller, right? Midline. So you don't have anything to compare it to. The minute you have something to compare it. I'm most nervous when I have a central and a lateral to replace. That's when that is the toughest thing to do in implant dentistry. Replacing a central lateral, right? Or a canine lateral. Those sort of that adjacent implants is the toughest thing to do. Today we don't have the time to get into all of that, but there will be some point in time when you'll understand this when you're doing this yourselves. When you're dealing with post-extraction defects, you need to see what is the span of that defect, where are you going to place implants, are you replacing one tooth, multiple teeth, and all of those things. And you also need to try to understand what kind of restoration you have to do to bone and soft tissue. That is what more important over here than anything else. Sometimes you have simple situations like this, where you have an interbony defect. Sometimes you have a hard and soft tissue defect like this, which you need to graft simultaneously. Or you have a very complex defect like this, which is vertical, horizontal, everything put together, right? So if you want to try to fix these, they become even more difficult, right? So this is typically a roadmap that I follow to decide on what to do when. I may use different techniques, but I always use different techniques for different situations. So this is like my roadmap to follow. You can follow your own whenever you have the experience. So for a simple one like this, I'll do a straightforward contour augmentation, place your implant, get in a collagen membrane, put one graft over there, close because she already had a Maryland. I just had to give her that Maryland back as the provisional because I want closure. When I'm doing GBR, I want closure. Go back in, the second stage, you can see how well we've managed the peri-implant phenotype that we're talking about, mucosal thickness that I want, the soft tissue height that I want. Once I've got all that in place, I make a provisional and condition the tissues. So when I make a provisional, I will allow this soft tissue to creep down, get the papilla back. Remember, the papilla belongs to the interdental height of bone. So as long as the teeth is intact on the neighboring tooth, you will get your papilla back. Okay? If you've lost it on the neighboring tooth, then you've lost it. That's it. You can't do anything about it. So we allow the papilla to come back and then go ahead and place our final restoration, which along with whatever else is being done, gives you that final outcome. Sometimes you're doing grafting and hormone and soft tissue grafting simultaneously, in which case the soft tissue graft has to be pedicled. It cannot be a free graft. If you do a free graft, it will not survive. So we do a pedicle after collecting bone from the palate and flip the pedicle over to get soft and hard tissue together. And you'll see where we started, where we ended up with the defect, and how we corrected the defect, right? Corrected to a convex profile, and then finally place your provisional, and then go to your final restorations to get that contour, right? So that's what the aim of our procedures is. When you have defects like this, you need to do more involved surgical procedures like this is the split bone block technique, where we take a block of bone, split it, and then use that as a wall to recreate the bone that we've lost, and finish with with, so you remember the defect, it was a big vertical defect of 600 millimeters. All of that is corrected with the grafting that we do. Soft tissue again often requires some kind of augmentation, and the three things that you can achieve with soft tissue grafting are only increasing keratinized gingiva width, increasing mucosal thickness, or a combination of the three. And that's all it is, right? Soft tissue grafting procedures are only for this. But there are different techniques that you can use, and these are all the possibilities out there. So you take a look at a case like this where you can see the green of the cover screw showing through. That's how thin it is. And just to show you that these can be achieved on implant models as well, where we take do a very superficial incision, which is partial thickness, split the flap, because you want a connective tissue bed to place your connective tissue flap. So you go ahead and split the flap, go to the tuberosity in this case, de-epithelialize and place the connective tissue, stretching it out to get the thickness that you want. And then when you look at this case, the way it heals, you see from where we started, where we were actually seeing a show through almost of the green, to this thick, beautifully keratinized soft tissue that is now not going to go anywhere. It's so robust, the tissue. And you finish it like this. We've already lost some bone out here, but as far as we're concerned, this is a long-term outcome for this patient. Like I said, that midline thing doesn't matter because there's nothing for you to compare it to. All right? So the same old conclusion slide, so I can skip this now. Thank you so much for the invitation, and thank you so much for time to listen to our
Thank you so much. It was a privilege to attend your talk, actually. And I'm sure we have plenty of fans here for your work and your photography. Thank you so much. Do we have any questions from the audience? I request our chairpersons to kindly say a few words.
Just placing an implant is a very easy job. Maintenance and especially the gingival features, which has to be maintained very well, so that he has done a very good implant cases.
Thank you.
That was a wonderful presentation. Right? There are two things that I would like. Your experience on hybrid processes in these cases. Okay. That is one. Of course, you have managed this soft tissue very well. There is a innate need for the hybrid processes. But do you have any of these?
Yeah, so we do several of these cases where you already lost a lot and you need to replace hard and soft tissue in the prosthetic. I think that's what you're asking about. Yes. So if you do have to do that, then you have to ensure that your transition line is taken way above your flip line. So we end up actually taking out sometimes 4 or 5 millimeters of bone to move the transition line up. That is something that goes against my...
In compromised cases where you are able to rebuild, of course, you have managed it very well.
That's true. So it's not for every case that we build this thing. So when we do, we try to keep prosthetic designs as easily cleanable as possible. The problem is that most of our, especially when they've lost so much, we end up with a flange because we replace soft tissue. I prefer to do a bar and bar overtension in those situations and trying to. So it's like an FT4 kind of a thing, right? That's sort of the situation I'd rather do a bar.
Secondly, any particular protocol that you follow for the post-op or hygiene maintenance for patients?
So I believe that getting the right kind of, most of the time patients like this who are, like he said, one of the best motivators is to charge well. You charge for every step and the more you think that they learn that, okay, when it is costing them dearly, they will learn to take a little more care of it, but not everybody is like that. So one of the things that I find is most important from the point of view of being able to aftercare is being first of all able to develop the soft tissues and so on the way we have. But apart from that, it is prosthetic design. After time we fall because of the prosthetic designs being faulty. If the critical and subcritical contours are well designed, there will be no biofilm formation below the surface. If there isn't, there will be no issues. Whatever, even in those cases when you have lots of plaque on top of the restoration, you will find that there is really no inflammation going on below because the biofilm doesn't form. So I think that is the most critical aspect of this. And yes, we do have our recall regimes where they come in. The first year it is once in 3 months, and then after that, depending on how well they maintain, and I am very fortunate that I have a periodontist for a wife, so she takes care of a lot of this. Thank you.
Thank you, sir. I kindly request our chairpersons to present our guest speaker with a memento and a certificate. I request Dr. Ravi Shankar sir to kindly present a certificate of appreciation to our guest persons. Keeping aesthetics as the forerunner, I'd like to call upon our next guest speaker, Dr. Ashish Shetty, on the topic of imaging and diagnosis, organized by Dr. Rakesh, Professor and Head, Department of Oral Medicine and Radiology. Sir, the floor is all yours.
You to do a small work. And just close your eyes for a second. Just imagine you walking. Imagine. You can walk, right? You can walk, you can run, you can fly. Just imagine, rather than imagining, closing your eyes and you're walking. Will that be possible to do for quite a long time? No, right? So that's how, see, this screen, the whole screen is totally black. Everyone has been talking about there are a lot many amount of colors which has been shown, described, explained. Okay, this is how most of the time when we tend to come for a diagnosis. Most of the time we are blindfolded. We exactly don't know what exactly is happening. So although there was an accidental discovery of certain amount of rays which was there in the late 1800s, following the accidental discovery of this, the evolution of this X-rays, which they have called it as an X-rays because it was called unknown, nothing has gone anything with unimaginable things. There are certain things which have been happening sequentially, which has been used for diagnosis. The same way how the Mr. Sir William Röntgen made a radiograph of his wife's hand. As you can see, there was an amount of exposure was around 25 minutes. Following that, Dr. Otto, who has been the first documented person to make a dental radiograph. Okay? From there, the evolution has started towards two-dimensional imaging. Here we can see this is what we have basically been exposed to. As a student, as a practitioner, we've been seeing the most amount of panoramic images. And in relation to the panoramic image, there is also an image on your left, which we tend to see there's sort of a lighted lesion, which is not that much amount, which has been presented in relation to a panoramic radiograph. So that created an evolution again towards the introduction and the usage towards to the three-dimensional imaging. Okay. Now this is the image what we basically are seeing right now. Now this is the one imaging which I am showing because we've been exposed to the images from the dentistry in relation to the conservative part to the fractures part. But I am speaking in relation to a soft tissue. Okay? Still there, to the further evolution, to the imaging, the fusions of certain amount of modalities which have been there, where we tend to decrease the amount of exposure. To the latest one, like how Ashish sir told, we are more into the photography. We want to take selfies. So much amount of younger generation who wants to go for beyond photography. This is a radiant photography where they are trying to use the radiation for the assessment, for the beautification, for the capturing of certain amount of natural things in the whichever is there in the nature. Okay. So this, let me introduce myself. My name is Rakesh. I represent team Old Medicine Radiology. Here we are present to have a discussion about the imaging and the diagnosis, the usage of three-dimensional imaging for diagnosis, treatment, better understanding as well as for learning. Now I want to steal the quote what Ashish Shetty sir told. Actually, I was a student, sir probably does not know. He was the only person, in case if sir scolds also, he never used to feel bad. He used to scold in all languages. I used to feel really happy because sir probably does not remember me. One of the things is, the basic thing for any knowledge is experience. We are trying to get the best people in radiology to have a discussion. We're going to have a discussion about the imaging as well as the diagnosis, the usage of that. So first, let me introduce one of the first stalwarts, Dr. Praveen Giru sir. So I would like to request Dr. Praveen Giru sir. Dr. Praveen Giru sir is Vice Principal, Professor and Head, Department of Old Medicine Radiology, KLE, Bangalore. Sir has got a lot amount of publications, has got a highest amount of citations. Citation ranges more than 1,200. Sir has got a lot of honors. Sir has been the best outstanding faculty in 2011, which has been honored in the 95th KLE Foundation Day. Sir has got a lot amount of contribution to the science. Sir has got a lot amount of patents which has been published in sir's name. Next, I would call upon Dr. Vishwanath Andol sir. So, sir was part of our institution, even if it was called as Ramaya Dental College. Sir was there, and then sir went on to head Department of Old Medicine Radiology, Indira Gandhi Dental College, Pondicherry. Sir is a private practitioner. Sir practices from aesthetic dentistry to implants, and is also an avid teacher. So, sir has an experience of 22 clinical years. Has got several other publications and also been invited as a guest lecturer, and sir also takes part more into the community service through Lions Club. The next person is Dr. Seema ma'am, Seema Patil ma'am. Seema Patil ma'am, she is heading the Department of Old Medicine Radiology, RUAS College. Ma'am had been to Japan for 1 year course where the introduction of CBCT had not happened in relation to India. Madam had undergone a course where she got literally trained for a year in Japan. The next person, Dr. Vinod sir. Vinod sir is the only person in Karnataka who is running 20 plus CBCT centers. 20 plus. The next person to be called onto the dais is Dr. Revan Joshi, a friend of mine. Sir is also a faculty in RUAS College. He is a consultant radiologist. He is also an associate dentist in Nagesar's clinic. And he is a general secretary of South Asian Society of Oral and Maxillofacial Implantology, India chapter. Now coming to the major part, the honorable panel discussion. So now that we have introduced all the guest members, the panelist members, I want this discussion to be a sort of two-way speech. So I would request you people to ask the smallest of small questions, whatever you have, whatever the bigger questions you want, because knowledge is about experience, like what Ashish sir stated, and the more we tend to exchange the knowledge, the more we tend to retain the knowledge. The more we tend to retain the knowledge, more we tend to be helpful to the society. The society per se is what we are trying to do, like what Giants have told yesterday, correct? So we are supposed to give it back to the society. So the knowledge is acquired not by reading, it's about exchange. Okay? So let's go around now. So first and foremost, I would ask Praveen sir. So what do you think, sir, about the role of CBCT examination in routine dental practice?
Yeah, thank you all. Thank you, Rakesh. I think the CBCT is the one which has revolutionized practice in dentistry. So we had CT for some time, but the concern was with the radiation exposure. And then we didn't have that provision to modify ourselves for maxillofacial region. And then what really revolutionized was the on-beam computed tomography. And that I'm sure the experts or even the general dentists who are today practicing is finding so much of value in this CBCT. So let me make the ball roll. So I'll just run through a few slides, especially keeping in mind the undergraduate students who might not have a real exposure of what a on-beam computed tomography does. So do remember it is a three-dimensional. You have X, Y, Z axis. That means whatever the region you are imaging, you can see from front, from up, and from the lateral aspect. The lateral aspect is the one which you are all used to it in two-dimensional imaging. That's the sagittal plane. So that's how the sectioning is going to be done. So these are the three axes. You can choose the region of interest. That's more important. So reducing the exposure for the patients. So you have a provision to do a small field of view and get all the three axes imaged. And you need to imagine how the structures will look in three different directions. So this is how a mental foramen, how it looks from the front, how it looks from above, and how it looks from the sideways. So do keep in mind that you always, if you have a doubt, look at the one which you are more commonly used, that is the lateral aspect. So that's how. So this is what you are used to it, more common, and then you can imagine the same anatomical landmark on an axial view, which is probably from upward to downwards, and then a coronal view, which you're looking from as if you're standing in front.
So in case, can I interrupt you? Yes, sir. So means that you want to say that we can have an image rather than like a panoramic image. Here we are trying to see the image from top, from side, as well as from the top. That is what you mean to say. It means
Front, side, and top.
So what will be the basic advantage of this? If you are trying to see a normal photograph, a normal panoramic photograph, how would this be different? How would it be useful to any person?
So two-dimensional radiographs was imaged of a three-dimensional object. So all the three dimensions were not captured in a two-dimensional. So now this one-beam computed tomography is allowing us to see in all three dimensions. So that the three-dimensional, which was imaged in two-dimensional, now we are going to see all three dimensions. That's the biggest advantage of CBCT.
Sorry.
Yes, so I'll just move forward with a few more slides. So let's start with the case discussion. I think that makes one interesting. So look at this patient had difficulty in locating canal. I'm straight away going into endodontics. So if you look at the first one is the sagittal panoramic, which you are all used to it. And then you go for a cross-sectional where you can see an additional row. So now what has happened in this panoramic to here is you have sectioned it laterally as well. So when you have sectioned it laterally, so imagine you are slicing those area of interest. So this is where the new root emerged. Let me make it more clear for you. So you took an axial section, then you see this additional root here, which you would have certainly missed in a two-dimensional imaging. This is as clear as it, and this is how the additional root looks on a coronal section. So if I look at a 3D reconstruction, specially used for the patient education, you can clearly appreciate an additional root. I'm certain this would have been missed in a two-dimensional imaging. So this is the biggest advantages of slicing it of all sides to understand better.
In case, from my understanding, in case if I ask you, probably in case we could have made an IOP radiograph, the probability of me missing this root would be there?
Yes.
That is what you
It's probably 100% you would have missed. So if you go back for the earlier one, you would have missed nearly 100% an additional. So this year you don't even look that there's an additional gap.
So that's when you start sectioning. So you slice that area of interest, and then you find an additional route, and then you go for other dimensions, and especially the exit one. Look at the other route which is so clearly visible. So that's the biggest advantage of an three-dimensional imaging, especially the 2D.
Do we usually follow this slot technique or tube shift techniques in the clinics where we tend to analyze this, or you feel that that would be a better option rather than going for CBCT whenever in doubt?
Yeah. So slop was used at a different angle to identify. So let me make this slop technique would not be as easily as interpretable as this. Slop technique still needs some technique. Slop techniques still need some expertise to understand or interpret those images. But these are ready images. You know, even a general practitioner, when you ask for these kind of sections, it's so much readily available. The slop might, yes, it might have given you something, but not as clear as this. Okay. So I'll run through two more cases before we go. The most important is the resolution. There's one point which would like to drive to the audience. Now, resolution is trying to identify the area which has a discrete in the images. So now if you take the machines, there are low dose, high dose radiographs. So this is basically keeping in patients' radiation exposure. So what you need to do is you can choose a voxel size. So voxel is a volume. So when you choose a voxel size, and between 0.2 to 0.3 to 0.4 millimeter, you can see the clarity of images. So 0.2 gives you much more clarity than 0.3 and 0.4 millimeter. But do keep in mind, supposing you want a RUAS evaluation, then probably you should not go for 0.2 because it increases the patient dosage. But if you have something very, very specific to look at, small region of interest, maybe you can go for a smaller voxel size. It gives you more clarity of images, but do keep in mind that it increases the radiation exposure. So it's always benefit over the risk. Not that I always say 0.2 voxel and I want everything to be there. The exposure to the patient should be the paramount before you decide which voxel size you want.
So you mean to say, can we get this thickness in IOP or parachromatic? Is it possible?
Yes, you don't have this provision in any of those images unless you do the slices.
Especially in relation to these sections, probably we won't get it
in the regular conventional radiographs.
How would it be helpful, sir? Like in case going at a 0.3 mm section, as in comparison to a 50 mm section in a panoramic radiograph or IOP. How would this be helpful?
So this is to be more specific to identify something. So now if you are looking at an mental foramen, and then you have some periapical radiolucency, probably superimposing from an periapical region. You need more details of those region of interest. That's when your diagnosis, you're not able to arrive at a diagnosis. There is something you need more information, probably you have to go for a smaller process.
So can you just tell, sir, like, what would you prefer? CBCT or resolution or two-dimensional image? You would prefer?
So ideally, yes, you do your two-dimensional conventional imaging. You cannot jump into the one-beam computed tomography for all the patients who walk in. No, not at all. So your intraoral periapical radiographs gives a lot of information, yes. But there are scenarios where you would like to see it in a three-dimensional, more in detail than a smaller voxel size and CBCT. So CBCT can't be the straight radiograph to be advised. So it has to be complemented with the conventional radiographs.
So, from my understanding, just asking, let's assume there are dental caries which is trying to involve the lesion or distal pulpon, keeping the resolution in front, like how you said. Can I use the CBCT for the evaluation of dental caries? Is it advised?
Not. I mean, you go for a bite wing, I think it gives you a good information, especially bite wing radiographs. If you're looking at caries which is approximating and you're not sure which are dental pulp. Much more feasible in a small dental setup with your regular intraoral periapical radiographic machine. But you need some more information which that patient you're not sure, your bite wing doesn't, then probably yes. So you should always keep in mind how my CBCT will add value to the existing radiograph. It cannot replace it, but it should add some additional information apart from your conventional. So let me run through the next case scenario. This was the patient with provisional diagnosis of periapical abscess in the maxillary anterior region. So probably the resolution, this is the suspected lesion. So this is what your panoramic gave. So the moment you go in for a slicing, so you have much detail of the extent of the lesion, erosion of the cortex of the bone, and then of course you too can measure it to the large cystic lesions and the axial section as well. How is the corrosion, the erosion of the buccal cortex, extension of the lesions, and this is for the patient education. That's becomes very, very clear and effective for patient to understand how big the lesion are and what are the structures affected. And whenever you do a measurement, so this is 3D reconstructions might not be very accurate. You need to look into the slicings, especially for measurements and the interpretation of images.
Yes, so this gets to one question that whenever you are making a panoramic radiograph, you basically teach that the position of the patient is supposed to place the arch in the focal trough. In case if a person is writing in front of the focal trough or behind the focal trough, or in case if the person is shifting his head, do you think there would be a certain amount of changes in relation to panoramic image?
Yes, sir.
Certain amount of disparity?
So certainly, positioning is very important to understand, and especially when you are measuring something in few millimeters. The position of the head is very critical when you image. That's the fundamental which we need to do it.
So you tell that in relation to CBCT, no matter what the position of the patient, the head is, so we will get the accurate sort of measurements as in comparison to a panoramic.
Yeah, but as a standard procedure, you please position in the standard format. And
yes,
as cephalostats these days, they are not rocket science. There are enough guidance to see that the position of the head is improper, especially with the newer machines. And capturing images is not really a big challenge. And the head position in the focal trough of an OPG and to get the same side of image in a CBCT is much more easy. Okay. So let me go to the last case of a maxillofacial trauma. This patient reported with a trauma, a very faint ridge of symphyseal fracture, which needs a very closer look into it. So this patient was subjected to the reconstructed panoramic. So I would like to draw the attention of the audience to a reconstructed panoramic, to conventional panoramic. Look at the amount of clarity you have in diagnosing the symphyseal fracture. And this is the same thing in a sagittal section. You can see at what plane it has fractured. And then these are the few more slicing of those regions. This is axial, showing the fracture. This is the coronal. And this is the three-dimensional imaging. And of course, in the 3D reconstruction, there are two images. Here it is how it looks like. The vocal cortex is masked. The same view from a lingual side, as if you're seeing from the patient inside the mouth. You can see those impacted teeth and the fracture line. So in this specific case, this has the 3D dimension is so important to understand the fracture line and from where it is running, which would have missed in a patient regular examination. Especially this patient didn't have a deranged occlusion. He had a history of trauma and pain, and then that's how the three-dimensional complemented the conventional radiograph parameter diagnosis.
So, like my understanding is whenever you make a panoramic image, so we also tend to sometimes see certain amount of fracture lines. Sometimes we also tend to miss because of summation, probably. So, but that in relation to CBCT, the probability is
very high.
less.
And you are likely to mix the fracture line if the fracture is along the line of the X-rays. So in 2 dimensions, you certainly will miss if the fracture is along the line of the X-ray beam. So that limitation is addressed in 3 dimensions. So that's the biggest advantage. So do keep in mind that you need to imagine you are seeing in all 3 directions. You should imagine you should know the normal anatomy of the structures, and then how will I read this? You go for the most comfortable, the sagittal view. You can do the slicing at sagittal view. Then you can just reconstruct it yourself. You see it from the front and from the back.
So for any fracture case, basically they tend to go to any hospital. They would have advised CT. So what do you prefer as a dentist, CT versus CBCT?
Oh, certainly CBCT. I mean, especially if it is a bony structure. See, CT probably you will look into when you need more of MRI or CT when you want more information of soft tissue. especially traumatic, there's no need of CT. This covers the entire maxillofacial region with a very much less radiation exposure. So CBCT, I think, nearly replaces CT, especially for the bony understandings and the lesions.
Your reliability is about CBCT. What do you think about heart issues?
It's very much reliable, but you need, see, the CBCT 2 points is, please understand, why are you advising CBCT? What additional information it will give from the conventional radiograph? And then the interpretation. See, it's not easy. When especially you do a large field of view and you have to go through the slices in all 3 dimensions, it takes nearly 1.5 hours to really read through all those sections. So a specialist-driven center who can really interpret those images, identify the incidental findings, and make the reports more reliable is much desirable, rather than you get a whole volume and you don't know what to do with that. A report signed by a radiologist, oral radiologist, who can understand the anatomical landmarks and incidental findings and about the lesions, I think will make a lot of difference, rather than
Do you think the report has to be reported by a specialist?
Yes, I certainly go for it, because it's not an easy task to report and full work.
What is your take on soft tissue versus hard tissue versus?
So soft tissue, yes, it doesn't give you much information. It doesn't give you much information. Probably the recent advancement, you try to add few more features, fusion or MAT, but a conventional, or not say conventional, the regular CBCT, the soft tissue coverage is less.
Sir, as an academician, so what are the cases which you tend to get in the institute asking to CBCT?
So the most commonest is implant. I think that's the most favored department for asking for cone-beam computer tomography, because to know about the strength of the bone, the position of the implant, and it gives you a 3-dimensional, you can simulate. So the most commonest is the implant, and of course then comes the challenging cases, whether it is an endo or traumatic trauma these days. Even with conventional, we do 3-dimensional for all trauma cases. And then follows by endodontics and periodontics for some amount of bone length, and orthodontics is for the analysis, air space. And
As an institutional person, where do you feel you have certain amount of challenges in your trying to execute in institutions?
in the institution setup, it is more of an purely an academic. So we need to educate more to when to ask for a CBCT. Because there is an impression that you ask for a CBCT and you get a lot of information, all the information which you want. Especially the postgraduate students think that CBCT answers most of their questions. It doesn't. So we need to have a very clear objectives, what we are looking for. And then speaking to the radiologist will give you a much clearer what to expect from this kind of thing. Rather than just advising you, say, I want a CBCT of this, and then coming back asking, I can't see this, I can't see this, it becomes much more difficult.
Any questions from the audience? Please ask any question. No? You have understood everything? Yes, ma'am, please.
It's not a question, it's to add.
No question from my side, but just one information for postgraduates I would like to add. First case, sir showed about the radix entomolaris, cons species they can understand, endophages. Radix entomolaris we advised. Actually we suspected from radiograph that there is additional root. Under microscope we could see the orifice, but we were not able to insert the file inside. So we wanted to say exactly, reconfirm the position of the canal and what is the angulation. You could appreciate in that first case, the root was completely mesially angulated. That is why we were not able to insert the file. So we then angulated the file and then we got the canal. So that is how CBCT, additionally we got help from it. That's what, one information I wanted to add.
Thank you, ma'am. Thank you so much. Let's move on to a perspective of a private practitioner. Practitioners for since 22 years, practicing radiant aesthetics, 2 implants, 2 RTAs. I would ask Vishwanath sir, so what do you feel, sir, as a private practitioner, as well as to a person who is involved with radiology, what do you feel the role of two-dimensional versus three-dimensional?
Yes, to begin with, in your clinical practice, you will of course start with your two-dimensional radiographs. So it gives you an idea as to what is happening. And then you supplement or complement your two-dimensional radiographs with three-dimensional imaging whenever it is absolutely required. That is what I do in my practice. So I start with IOPA or definitely an OPG, all right, an IOPA or a OPG, and then my recommendation or my prescription for a CBCT would be for two reasons. One is preoperative, one is post-operative, and sometimes intraoperative. So pre-operative, of course, to make a diagnosis. Especially I ask for CBCT in implant cases, especially in your endoosseous implants, where we have to measure the length and width of the bone, the proximity of the sinus floor, your inferior canal, and so forth. So that once I get that volumes of images, I take some time, interpret the images in all the sections, in your axial section, coronal section, sagittal section, and then come to a very conclusive mindset and mental picture that okay, my implant will go for this length and for this width and for this angle. So I will have a very clear picture with regards to my implants. And secondly, that suppose I feel that I am unable to make a diagnosis for endodontic purpose with additional roots, root canals, then of course I will ask for a CBCT. And sometimes, of course, you have especially maxillary canine impactions, and sometimes your mandibular third molars. If at all I feel the root, tip of the root is very close to the inferior canal. These are the usually preoperative reasons why would I ask for a CBCT imaging. Post-operative, again, your implant imaging, and then failed cases, failed implant cases, failed endodontic cases, and so forth. Mostly these are the common reasons why I would ask for a CBCT. Intraoperative, very rarely. Suppose you open the access and then we don't, we find, as ma'am said, sometimes you do feel that there is a additional canal or additional root and we don't get an access. Where the orifices you want to detect, those are the times very rarely we get to advise. But usually these are the common reasons I would ask for a CBC.
Yes, so now that you told that what are the common things what you basically ask for, each of the things have got different sort of requirements. So how do you communicate with the CBCT center people? Like you tell them, you give a call and tell them that
of course, it's very important to give them a history because they will want to know what is that I'm looking for. Okay, they will probably give a general report otherwise, which I may not be needing. I just want some specifics.
Sorry to interrupt. So you mean to say that you should speak to a CBCT center for advice?
Very, very important. You write it down, and then if the radiologist needs some more understanding, you talk to them, and then see. Basically, you need to give good treatment to the patient, end up with a good clinical case. You have to spend additional 15-20 minutes talking to the radiologist, speaking to them as to what exactly you are looking for. What you have communicated in writing may not be understandable by to the radiologist. So just take 10 minutes of your time and their time, and then clarify everything, and they will have a very good idea as to what you are looking for. So that makes the things go smooth and smooth, easy.
You tend to tell that you need to have a proper communication.
Absolutely.
Now that you have communicated to a center or to an institution, now they send you back a certain amount of data, be it in the form of a CD or be it in the form of a report. Which do you prefer? You prefer to read a report because most of the CT MRI people are following with the reports. They don't look at the plates, they don't look at the slices.
It depends on how you are trained. So because I am a trained maxillofacial radiologist, I do look at all the sections. I take 1.5 hours, read every section, and then I form a mental picture. Okay, this is how my treatment plan will work. Otherwise, if you are not trained in doing it, probably the reports would help. And of course, as Dr. Praveen mentioned, that a qualified radiologist sending it would be more accurate. And then if at all you have the patience and if you have the will to study all the planes, it will be nothing better than that.
So let me put it like institutional versus private practice. So Madam Sriman, in case if I ask you, would you tell that should there be a special training for understanding three-dimensional imaging? You feel that they should be at the undergraduate level or at the postgraduate level or to any private practitioners?
I feel it should involve all the levels. Whether it's at the undergraduate level, maybe at internship they can undergo. And I think it's also required at the specialist level. Actually 2 years ago we had done a survey just to get an understanding from different specialities that what are the situations they actually advise and when they don't. So just to have a good idea. So at the end of the survey we realized that not just, we always talk about students, but since this is a specialty in itself, the other specialties also need to be, I wouldn't say educated, I would rather put it as a little bit of an awareness in what situations that they should actually advise CBCTs. Briefly to all specialties is what I feel.
Yes. So it means like as an institution you tend to get very young minds who are ready to accept, like Praveen sir sees, Seema madam or even Joshua sir, any one of you see much among the younger population in a dental college. As a private practitioner, I am also 20 plus with clinical experience. Do I have that capability to sit and listen?
Okay, subjective. No, yes, developing a skill is always important. You develop your skills, you are ahead of your time. Anything for that matter. As a practitioner, I would always want to develop a new skill. So that is the way of life now. That is the way of you're practicing medicine now. So yes, if I sit and learn, I take that extra time to learn how to view structure in 3 dimensions in all the 3 planes. That will give me such a fantastic understanding of the structure, one thing. And then of course, it's fun, it's fun visualizing those structures. Even for the smallest of truth, if you seeing it in 3 different planes and you are understanding or you're seeing newer things which you've never seen before, it's a lot of fun doing it. I have a lot of fun visualizing these things. But of course, a lot of practitioners may not have the time. But of course, as I said, anytime developing a new skill is a fantastic thing to have.
So you can say, both from the academia as well as from the private practice, we should have much more amount of common dental education, of continuous dental education. You basically tell that we have to expose to most of the people a small amount of it, how it is useful, right? That is what basically I am trying to understand. I guess please correct me in case if I am wrong.
So I think it's the rapid changing in technology. I think all of us have to invest some time, irrespective number of practices.
So we have to get and any suggestions are towards the center, because sometimes you could have asked for something else, sometimes you could have brought something else. Because of the world of digitization, you could have asked for some other patient CD. You get some other patient CD. Can you identify this is the patient's? Because in an IOP I can't recognize.
Yeah.
Everyone is talking about you're supposed to have a digitization. When I make a radiograph, I can indirectly digitize by taking a photograph. But can I tell, is this CBCT of this person only? It is not of some other person X or Z or Y.
Of course, you will clinically correlate always and see, right?
And you always have that data set which is always there.
Correct.
The patient name, age, and because everything is there's a date stamp. So Joshi wants to add something.
The latest digital imaging technology has to conform to DICOM settings. And DICOM settings has inherent patient data in it. Wherever you are reading, whichever DICOM format you are using, whichever third-party software you transfer it to, the patient data, if the original machine which captured it has not transferred it as without the patient data, you will always have the patient data and you can always look into it and identify which patient it was. But if I am taking the image and I want to make it innominate, I mean there is no name of this patient, if I am going to use it for research purpose, then I can transfer the data without that personal detail with it. Generally all the all the centers give you DICOM files, and they will have the patient date, date of imaging, date of birth, name of the patient, sex of the patient entered into it, and this will carry on with it. As long as you are using the same DICOM files, you will definitely have those things.
So we always can tell that in case your patient is asking, this is not my CBC. You always have a
Unless the center has given wrong name to it.
Wrong information, because there is a human error also which is being done. Like, let me ask you one more question. Like, we are famous for our selfies. Even the selfie, in case if I take a selfie, I look like an American. So, do you have a capability of changing certain things in a single city where there is no lesion, you can make it look like a lesion? Because in the world of digitization, is there anything? Sir, you want to answer that?
We can't do exactly what you're asking for, but in a 3D reconstructed view, you can definitely play with the images, you can increase the contrast, reduce the contrast, it's volume rendering. Sometimes it always gives a wrong impression than what exactly the actual scenario is. So we should never trust the 3D images, but the multiplanar images what we are seeing, that you can't change.
Sorry sir, I didn't understand. So you mean to say that I basically use these 3D images for diagnosis. So you're basically telling that probably that should not be done.
Yes.
You're not
3D
supposed
images.
to use a 3D reconstructed image for diagnosis.
3D reconstructed images, what we see in the CBCT file volume. If you see a CBCT volume, there will be 4 windows. And the 4th window is always a reconstructed view. The reconstructed view is there just to give an idea. That will not give you a perfect diagnosis. So you taking decision, looking at that 3D reconstructed view, you can go wrong. Okay, so that can be altered. But the other multiplanar images, the coronal, sagittal or axial, that can't be altered.
So we are not supposed to use a 3D reconstructed image.
Exactly.
Then why are the companies providing it?
That is, first of all, you can use those images to educate the patient. That gives very good impression. Whatever you talk, whatever you say, unless the patient visualizes, they are not 100% confident on a dentist who is going to treat it. So that can be used as a educating tool for a patient.
Yes sir, because I ask this question because sometimes some of the private practitioners call us and then they tell that 3D image is not coming. I am not able to diagnose. So how do you help them out?
3D images, first of all, if I want to tell, their laptop, what they are using, or their computer, what they are using, that should have a proper graphic card. Okay, that should meet certain specifications. And all the time, they don't have to trust the 3D images. They don't have to make their decision looking at the 3D images. It is the report or other multiplanar images that have to be looked into and made the decision.
So now, as of my understanding goes, sir, CT is always attached with the workstation. CBCT is always given with the personal computer. The patients are also having the same data. They tend to open, they tend to Google, they tend to come out with their own diagnosis. They come and tell to the doctor. So, what do you feel?
That's what. Their computer should have a proper graphic card to visualize the 3D image. If they don't have proper specification, the 3D image will definitely not appear on the screen. And I always tell they should make their own decisions. They shouldn't Google enough to come up with some wrong impression. They always have to learn to trust their radiologist or their doctor who is going to treat them.
The reason why I ask you is, can we take this as a specific tool for diagnosing, let's say, commonly TMJ issues? So looking at the way how the joint is presented, like pencil thin, parent appearance, osteophytes.
You mean to ask, can we visualize, CBCT can be used as a diagnostic tool for TMJ. Ideally, CBCT is not a ideal diagnostic tool for imaging your TMDs. CBCT can give, as sir told, hard tissue can be better visualized on a CBCT, but not your articular disc or muscles around them. So you can't come at a proper diagnosis just looking at a CBCT. Yes, of course, if there is a trauma, there is a fracture, as you told, osteophytes, or there is some resorption happening, or even if there is any malignancies, yes, that can be definitely visualized. But when you are suspecting some articular disc damage or any soft tissue interferences, then CBCT is not an ideal tool to visualize TMJs.
So we were discussing with Seema ma'am, ma'am was also telling that there is a possibility that we can fuse certain amount of images. So for the identification of the temporomandibular joint, so madam is just going to share her experience towards the fusion images. The basic ideology is CBCT is very good for hard tissue, not very good for soft tissue. Especially temporomandibular joint is a very complex joint where we have hard tissue, we have muscles, we have soft tissues as well. Sometimes making just a CBCT would just give us an idea about what the bony condition is, but would not give any much amount of information towards the disc conditions. So, madam is speaking something about the fusion image and the other volumetric assessment which can be done using this revisionized CBCT images.
Like Dr. Rakesh mentioned and Dr. Vinod also said, that CBCT has its own limitations. It's mainly useful only for osseous structures. So if you look at the images on top, that is the CBCT image, both are in the closed mouth position. So you can just identify the condyle and the fossa as well as the eminence. And in the second image, I have labeled it as anterior disc displacement. So here what I am trying to say is you can't see the disc. You can at the most appreciate that there is some space between your condyle and the fossa, mostly in the anterior aspect. Similarly, if you look at the image below, you have the MRI images. The orange arrow is pointing to the articular disc. It's seen as a hypointense area. And in the second MRI image, where the disc is anteriorly displaced, is also evident. Now, the problem with MRI is the osseous structures are not seen. So what I would like to say here is the contour of the condyle, the bony contour of the condyle is not evident in the MRI. So in the third, basically they have fused the CBCT with the MRI. And just to make it look better, a color has been added for the osseous structures. So you see that the condyle and the fossa appear red, and the disc, an outline has been given to the disc so that it is also seen. So what we are trying to say over here is, when you want to see pathologies both in the osseous as well as in the soft tissue structures, that is where a fusion image comes into picture. Okay, so the similar concept has also been applied here, where in the CBCT image, which is on the extreme left, you actually see a calcification. We do not know whether it is in the joint space or it is in the disc. And in the second MRI image, you're able to see the disc, but we are not able to identify the osseous structure properly. In the third, which is a fused image, it is evident that this calcification is actually within the disc. So these are a few indications wherein fusion can be done. And like we mentioned, it's a combination for both osseous and soft tissue, and also to check or to evaluate the relationship between the osseous and the soft tissue structures. It can also be used as an educational tool, wherein we can show the students, like, see if there is a displacement, how does the disc look like, where is it located, and also its relationship to the condyle.
So can I just wanted to ask, CBCT is usually made in standing position, MR is made in a sleeping position. Would you want to comment something about any adaptations which we have to do so that we can have a proper image? It is not like something like the layering which has been done in a photography?
See, these are all research related articles. They are not something that is being done in practice.
Rakesh, these images are taken and then they are used, irrespective of the position.
And I think so we tend to go for the anatomical landmarks. We have to identify the anatomical landmarks. That's the place where radiologists usually come. Any person can't fuse it. Probably they can fuse it with a mere chance. But the fusion, whenever it has to happen, you're supposed to have a proper knowledge about the anatomical thing, so which would be called as a fiducial markers, and then you try to merge with it. So at that time, we tend to get these images. Means these are basically for more amount of research, not like some photograph which is being merged onto each other. That's what you.
Basically, both.
The photography, I would like to interrupt here. Even the photography needs a lot of skills to superimpose. No, not everybody can do a good superimposition, even if it is the same fellow's photographs. Even lateral cephalograms need a lot of markers when you are superimposing them. Many orthodontists sitting here will tell that. And you are doing a 3-dimensional superimposition, it needs a lot of training. It is not a joke, and what ma'am is presenting now is probably the future, where we will have much more easier artificial intelligence related fusions happening, which is already happening. Stitching of CBCT images is something which is done using artificial intelligence only. So this will also probably come up.
Sorry to interrupt you. So now I just wanted to ask you a question. We are seeing a calcification between two bones. So can we also visualize any calcification within any of the head and neck structures?
Yeah, definitely. Like silolith. Yeah.
Any other?
Even tonsillolith, all those things, even antolith, all those things can be visualized. But for our practices, we are more concerned with silolith, especially in the submandibular gland or in parotid gland. If it is calcified structure, yes, definitely we can visualize with the CBCT. If not, then we have to do a specialized technique like xylogram, all those things.
I'll just move on to the areas where the volume assessment is being done currently. This is like where the volume of the airway, especially the upper airway, can be evaluated with CBCT. And this is mainly of use for orthodontists, because it has been known that certain skeletal relationships and airway has a close association. So what is being said is that especially in people who have a class 2 malocclusion, where the mandible is in a retrognathic position, the airway space, especially in the anterior-posterior direction, is slightly lesser. So what happens is when the airway space is lesser, they can have respiratory issues, and also they could develop sleep apnea issues. So from an orthodontic point of view, they would definitely want to know about the volume of the upper airway, especially with respect to the oropharynx. This airway measurements have been done, of course, with lateral ceph. It gives them an area and other measurements, but it is not as accurate as what you obtain in a CBCT. Also in mouth breathers, in chronic cases, the development of the maxilla and mandible is definitely affected. So in all these situations, an orthodontist needs to plan the forward movement of the mandible, whether he will do it with a functional appliance or whether he wants to do it by surgery, that a call which he will take. So basically I would want to say that in mandibular advancement cases, orthodontists do ask for a volumetric evaluation of the airway. Anything else if Joshi wants to add in the airway analysis?
See, this airway analysis, as ma'am told, predominantly is a function of surveying the airway. If you could survey briefly and see what could be hindering the airway, where is it actually narrow. But if you have to extrapolate this data to predict sleep apnea, which happens more often in the later age group, it might not be the right method of doing it, because as of now we have all CBCTs which are standing position. Sleep apnea happens when the patient is sleeping, first of all in the supine position. The airway gets laxed during sleep, as well as supine position itself is a different gravitational issues will be there. So if you are making a patient wide awake, standing and taking a airway volume in them, it may not actually represent the pathology that the patient might be going through. But yes, it will always survey and screen off major anatomical hindrances like what ma'am said, adenoids, or any other thing that is coming in the way of pharynx that can be identified. Sometimes you can enhance the images by asking the patient to have a swallow of barium, which will again enhance the surfaces of the airway and the oropharyngeal area, so that we can identify those areas nicely.
So for my information, so making an analysis even in a standing position can be equivalent to a sleeping position. That's what
it is not equivalent. Sleeping position is not equivalent to standing position, but yes, it will be at least a bit proportionate to what you can do, because you can't keep on making a CT scan for a patient for just analyzing the airway. So this is a better way of analyzing. Lateral surf will not give you the detail again, because you are going to do it in a standing position. About 20 years ago, there were a lot of studies. When I was doing my PG, also there were studies wherein the patient was made to lie down and a lateral skull view was taken to mimic that. But again, it was a 2D image, which will be having a lot of superimpositions, and you will not get the correct values there.
So till now we have been discussing that CBCT may not probably be a good one for soft tissue, but you told that we can give a barium swallow so that it will enhance. But now this thinking that it is a soft tissue, then why is it C? Because it is next to
CBCT works on a very low voltage and low milliamperes. So that contrast can be obtained in a CBCT easily, which of course you can do that in CT also with varying the parameters, but it is much more easy and it is at our hand. Dentists can use it left, right and center, so that should be the way ahead.
What basically I thought was because of the presence of a negative contrast area, air, in relation to the upper oropharynx, and in presence of the bone, this is probably getting enhanced.
Yes, wherever you have air or fluid combination, you will definitely get better contrast.
Why not do it on a panoramic radiograph? This will be seen in a panoramic radiograph as well. So why CBCT only?
You mean to say airways?
Airways.
Airways on a panoramic radiograph, the view of panoramic radiograph always comes from behind and below. So superimposition is the biggest thing, that is the problem in panoramic radiograph. So again, outlining the airways is very tough on a panoramic radiograph.
When it is coming on both the sides, you don't know which one you end up with.
And many a times we miss out on the airway. If we restrict ourselves to the TM joints, we won't even get the full airway on the panoramic radiograph.
How easy is it, madam, to put these DICOM images on ortho perspective? If they use Dolphin 3D or any other private third-party softwares, how easy is it?
Third-party softwares are fine, quite easy in coming up with the volume measurements. But not all the software which comes with the regulated they may not have. I don't think all machines have this volume assessment, but I think from a third-party software, I think Dr. Vinod is agreeing that it's quite simple to.
Now we have third-party softwares where we can get the volume of airway analysis.
Yeah, I think it's quite a simple.
Yeah. We don't have to break ahead. AI is there, so it does automatically.
Now that I'm seeing your presenters view, that you have got another slide of volumetric analysis for the bulk too. So you want to say something about the thoracic oncology evaluation with CBCT?
I just have a few slides which are being done for volume assessment in other fields. One is this pulp volume and tooth volume. Here, of course, studies have been done with the conventional imaging modalities, but again, with CBCT coming into picture, people want to see how effective this would be. So there are a few studies which are trying to assess the pulp volume to evaluate the age, because we know that the pulp volume actually reduces with age. I won't be commenting on how useful or not it is, because it depends on the populations which are being studied and what is the sample size you have, and again there are different techniques and methods which are being used to evaluate this. Also, the volume assessments has been done in other aspects of forensic odontology, that is for determination of the gender. in maxillary sinus volume, sphenoidal sinus, as well as frontal sinus. And I mean, like I said earlier, like we probably need more studies to be done to comment how useful these sinuses are for gender determination.
So speaking about volumes, ma'am, volume can also be seen in a cyst or a granuloma. So can that also be evaluated? Like I'm seeing your view. There's another slide where there is an evaluation of volume.
Yeah, I think there are a lot of studies where pathologies are, the volume has been assessed, and then further they are converted into models in the form of by 3D printing technology. I think Joshi can throw us more light on 3D printing and AI.
Yeah, I mean, all of us are using artificial intelligence in our day-to-day life. We all know our mobiles are very much more intelligent than us, and that's why they're called smartphones now. And they know when you are smiling, they know your age, they know your facial outline, they capture your ears better, they capture your eyes better, and everything can be done automatically, and that is what is application of AI. And similarly, all fields of dentistry can use artificial intelligence, and the future is going towards that, so that not everywhere radiologist will be there, and not for every reason you will need a radiologist to be interpreting. And whatever brains we have had about our intelligence can be transferred to a computer, and that becomes an artificial intelligence. So that part I will not be elaborating much, but 3D printing is probably one thing that has been hitting our market very nicely. The most commonest 3D printing machines that are now available in India start from price of about 8,000 rupees. You have FDA approved printers which can be used for medical and dental applications, which start from somewhere around 6 lakh rupees. And the most important thing that goes behind this 3D printing is that we are digitizing everything. Now, if you look at our method of what we were taught is to take a proper impression, pour them thoroughly, use a vibrator, there shouldn't be any bubbles, voids in the model. And then once we remove the model, many a times incisal ledges would have been broken, the crown would have been broken. Some part of the impression may not be perfectly registered. And all these imperfections, over and above that, we make a good model and take it with us to our locker room or whatever we are going to. And in between we bump into somebody and it falls and it breaks. I'll have to repeat the whole process again. But now with the advent of scanners, intraoral scanners, we don't have to do that. Intraoral scanner will do the job. But if in case you still have these models, like in orthodontics, they take a very good impression. They can digitize these impressions using a cone beam CT machine. They can scan it like the conventional, with of course some modification in exposure parameter. They can scan the models and store them as a digital data in their machines, and that can be converted into STL format and printed n number of times, anytime, as long as you have the file with you. So that's one good thing about 3D printing. A couple of other things that can also be done.
Because you spoke about two things. One you spoke about the AI, and one again you spoke about the 3D printing. Something which caught my attention of the AI, and so I was discussing about ChatGPT. I think everyone could have heard about this, right? ChatGPT. So you were talking something about an assignment of your daughter, ChatGPT.
Okay. Yeah, the fun part of ChatGPT. Like the university asked her to write an English essay, and then they said we have detectors which can, we have softwares which can detect AI drawn essays or AI output essays. So what she did was she asked this ChatGPT to write an essay for her. Then she modified with her own English. Her English is good. She modified it a little and put it back onto ChatGPT and said you paraphrase it. So it paraphrased it, and then she loaded it into a detection software, and it came out that it is a 98% human written. So you can always cheat the ChatGPT.
So sir, that's what, where my question comes. Can I use ChatGPT for interpretation of scenes?
But you need to put in proper data for it to understand, right?
Let me interview. Sir, ChatGPT is from OpenAI, a company called OpenAI. they also have a subsidiary which is a bit very small called DENTCON. They are into this process. They are trying to get a lot of data from us. I am very sure Vinod would be getting a lot of requests from Indian origin people from Australia and other places where they are asking for 2000 CBCT images, 1000 CBCT images. They are ready to pay us for that. You can remove the names and get it done. So this is the way it is going ahead. Already they are able to detect dental caries, at least give you red hotspots. If you feed a OPG to this machine software, it will start showing up some pathologies that it presumes as being pathological, and you just have to look at those areas more specifically so that you wouldn't miss on to something. So that level of intelligence has already come. And it is not that OpenAI only has done that. A couple of PhD topics in our RV Engineering College also did this, where they could assess the texture of images in a two-dimensional imaging and predict what it could be. Is it a cyst or is it a tumor on a panoramic radiograph? So these things are going on. I'm very sure that if the data theft from India happens, we will definitely have a more intelligent artificial intelligence machine.
Because you can also this is really complete. I look at we want a certain amount of images. So that was there, but as a student, let me ask, is it easy for me to write a radiology thesis topic using ChatGPT?
Yeah, if you are...
Because everyone are presenting in some conference a lot. Most of the people are presenting any case reports. Can I use this AI?
Yeah, you can. Absolutely possible. Absolutely possible. As I said, 18-year-old girl can do it. I think postgraduates, they look for this opportunity.
I would like to ask, sir, what are the other AI things other than DiagnoCAD?
There are so many already softwares in the market. Here you just have to feed OPG, you will get a report. There is one software company based out of Bangalore. If you have heard, Dr. Vinod is an endodontist. They have patented us. Not Vinod Rani. There is one more Dr. Vinod. They already have software, Roots Dental. They already have a software patented. You just have to feed in a OPG that gives all the diagnostic features of that OPG.
Sorry, sir, again, interrupting, because sir told that we need to have a radiologist reporting. Now we have systems generating reports.
But again, that has to be seen and signed by a radiologist. Not all the times what you get is right.
You need to say that it will generate, you tend to add or correct, because
Definitely.
the open system, open AI works on certain amount of neural networks.
And I've seen, sorry to interrupt.
It's there already in pathology, right? General pathology, the machine generates the report for you. It's a simple, complete breakdown. But there's a signature of the pathologist. I think that should fall in place. Before we wind up, I just want to tell about this data transfer with the foreign universities. Anybody? Be careful, especially the data protection bill of Sai Krishna Commission. It didn't go through for simple reason of influencers. If you look at the Google map, the way you track the Google map, they did it in US, they couldn't do it in India because of the small bylanes. And the only way the Google did was they made it as an open source. So the crowdsourcing happened. So whoever used the phone gave a source to Google to do it. And they are the big influencers in collecting this data. Now coming back to this data transfer with a person who is abroad, you need to be a bit careful. Suppose you have to a grant through an, say NIH and one organization, ABT or your association, then there is a very strong process that it has run through the ICMR, HMSC, Health Ministry Screening Committee. But when it happens between two private organizations, we don't have a control. So my only word of advice is just be careful when you're giving data to them. What are you getting into it? They will develop and they will sell it back to us. So that's just for all the people, especially with international collaboration, don't be a data provider. That will not help. You should be a part of it. You should learn through the process, and then your IPR and what your stakes at it, if that can be certified. We've been written in an MOU will help. Just an additional point, especially with data.
So now that you can't have this discussion for a longer duration of time, at least we have.
Just add on to it, artificial intelligence used in dentistry as of now is like a roti maker ad that you see in televisions. It shows beautiful rotis being made just by pressing a bowl of dough there. But if you actually try doing it, you will end up with horrible rotis only. Similarly, artificial intelligence is also in that phase as of now. So it will definitely need somebody who is more specialized to handle that and fine tune it to the needs of the current clinical standards.
So that's what I was stating. We can't have this discussion for a long duration of time. I want to cut it short and I want to end it with something which is what most of the private practitioners have used to implants. Failed implants and Vishnu said for us. I just wanted to ask about failed implants, the usage of CBCT for the evaluation of success.
Oh yeah, great deal, great deal. In the sense now, sometimes in the OPG or in an IOPA, now what I do is if it is an endosseous implant, I ask the patient to come back every month and then keep checking for how the progress of integration of implant with the bone is happening. And then I find it beautifully integrated on IOP or OPG. And then finally on the 6th month when I open it, and then the implant just comes out of your hand as if your guts are coming out of your mouth. Alright, so these things happen. So yeah, if at all there is a chance that last minute slightest of doubt is there and you want to check for the integration of the implant with the bone, you would be advised to look into it so that you don't fail the patient.
So how many times can you advise a CBC?
So yeah, once probably pre-operative, and then if it is absolutely necessary, post-operatively before you view the prosthesis.
Understanding goes, probably the amount of exposure in a three-dimensional one is slightly more, not slightly, much more, but much less as in comparison to the CT.
Oh, much lesser, and the duration of it's 3 months, 6 months, right?
I want to ask Sivan, so what do you feel about those amount of exposure to the patient, to the person who is using it?
Like you said, it's much lesser
I just
than...
wanted you to talk about your experience, what you underwent in the Japan, where you basically worked on management's usage of
No, actually Rakesh was asking me this yesterday, and he was saying in Japan they are being exposed to so much of radiation, so they're probably very careful in advising, or they take a lot of precaution. But that was not so. They did prescribe CBCTs. I wouldn't say quite often, but as and when required. So that actually points to the fact that the dosage in CBCT is pretty less, and I think a lot of work is being done on further reducing the dosage. But one thing we have to keep in mind is just because it is available, we can't advise it, because there is a model known as the linear threshold model, which suggests that anything beyond 0 can cause harm. Harm in the sense it can irreparably damage a cell. So that can result in cancer or some heritable defects. But again, this model is, there's a little bit of uncertainty about this model, and this is mostly done on studies where amounts of exposure have been high. So at very low doses, we are not sure whether we can accept it. But the only point I wanted to convey is, you advise it when you feel it is going to change your treatment planning. If you feel irrespective of what you get on the CBCT, you are going to proceed in a particular way, if that is already decided, then there is no point advising. So if it is in some way going to definitely alter your treatment planning, and it may give you some more input on the prognosis, then please go ahead. But otherwise, though there are two things to it. One is the dosage is very less, but it also, I would just want to say that it's there in the college, so I want to go with the CBCT.
So I'll come back to radiation. Radiation is harmful, irrespective of whatever. It is cumulative. It adds on from the time you are exposed. I'll give one example of these days fancy of carrying a portable X-ray machine. I really don't understand why you need a portable X-ray machine. You're holding a machine which emits radiation, which is harmful. A portable X-ray machine is basically more of forensic or a warfare. But the company comes in a package that a practitioner, I just want to do it. So what I'm trying to tell is radiation is harmful. Please be very judicious. Last ICMR data, 1 in 8 will develop cancer. US is 1 in 4. We are certainly going to reach there very soon. And in cancer, most of the things are not in control. So wherever possible, we'll try to avoid. That's the bottom line. Thank you.
Last question to you. So what sort of cases you get? You get more amount of old age patients, young age patients, kids? Who do you think are replacing?
To be frank, when we started 10 years back, when CBCT knowledge was very limited, 90% of the cases what we got were implants. And implants means middle-aged and older age patients. And today, after 10 years, when most of the doctors are aware of CBCT, they know where to use CBCT. Now it is almost 50-50. Implant 50 and other cases are 50. Other cases means, again you will be surprised, the first would be endodontics, next impactions, pathologies, and last would be perio or ortho, impacted canines. And again, the age, now it is almost older age people or middle-aged for implants and younger age for endodontics or impactions.
Because the reason I ask you is because sometimes you may require multiple times radiographs to be made for the assessment of the treatment whatever has been given. So it can be done provided case-to-case basis, understanding what will be the usage and disadvantages to the patient.
Exactly. Benefits. You have to outweigh the risks and benefits. If it is really beneficial for patient, if it is really going to change the treatment plan, if it is going to add on some information as ma'am and sir told, yes, you don't have to hesitate. All the precautions will be taken and a scan will be done. But if it is not required, definitely don't refer.
Final question. Sorry, sir, I think so we are actually the lunchtime. So what do you say, sir? What do you say?
Yeah, I concur with my fellow experts here that yes, at any point of time you feel that okay, my treatment is going to be the best with the three-dimensional imaging, I should go for it. Ultimately, what I'm trying to, the stakeholder is my patient. I need to make sure that I give the best to the patient. So if even one additional exposure helps in improving my quality of treatment, I would definitely do.
So questions are open for the forum. I don't think so I need to waste too much of your lunch time. Yes, madam, please ask. Yeah, give your back. Just please come out. First and foremost, thank you. Thank you for coming.
Hello. Every one of you discussed about AI. First you said advantages of AI, but I want to know what are the disadvantages and the ethical considerations comes with AI also. Do you think new laws should be, regulations and laws should be given since AI is emerging?
Yeah, it will evolve. I mean, considering the speed at which our Indian democracy works, it will take a much longer time to get laws and ethics into AI. But AI is the way ahead. I mean, like everywhere we are trying to bring in AI to minimize the amount of intervention, human intervention or variability. Wherein I'm not a pro AI person, but I'm telling you that's the way it is going. And definitely there are no laws, no ethical consideration being implied in India as of now. ICMR has a broad idea about it, but
so it's like your driverless car. So it crashes, now who is responsible? So the answer is still not out there. So, but AI, especially using artificial intelligence, just keep in mind what was the objective of that intelligence going to be used. You know, you cannot have broad radiographic interpretation. The AI might look well for a carious lesion, might not work for a periapic lesion. It's still a vast field, and it all depends on how much of data they are fed in. We are still not sure what is the sample size to develop AI. But the companies are coming out. So you as a practitioner should have a very clear understanding of what you are using for. At this present time, AI should help a reporting radiologist rather than making an independent choice.
At this outset, I would really thank you, sir, Sanju sir, Rashidi ma'am, as well as Sylvia madam. providing us a platform to speak about the discussion about the nuances of the CBCT. I would like to end this. I don't want to bother you during lunchtime. Madam, I think we can ask one last question. One last one. Yes.
As ma'am, you have shown about the dimension of sinuses and all. As we take panoramic radiograph, so a sudden tilt in the head position can change the dimensions in a panoramic radiograph. So my doubt is like how far CBCT is accurate in relation to dimensions.
Well, I know it is quite accurate. I don't think the head tilt issue should have an impact on the dimensions.
So the patient positioning won't affect the vertical and the horizontal dimension both.
If the patient moves during the take, then it doesn't.
Otherwise, even if the head tilt is there, it should.
Thank you.
Thank you. I thank all the panelists for coming and accepting to be part of this conference. Thank you.
What an engrossing session. The insights given by the panelists have been a pivotal in radiographic examination. I request Dr. Silju sir and Dr. Rakesh sir to kindly present the panelists with memento and certificate. Dr. Vinod Kumar. Dr. Praveen Berur. Dr. Vishwanath R. Dr. Seema Patil. Dr. Raven Kumar Joshi. Sir, I also request you to kindly give the certificate of appreciation to Dr. Rakesh. Thank you, sir. We now have a small break for lunch. I urge the students to grab a quick lunch and come back in another 10 minutes. So it's 1:30, so maybe around 1:40, 1:45. Can you please assemble back to the auditorium? I request Shri G. Shivar, Head HR and Legal, Gokula Education Foundation, and Dr. Lavanya R., Associate Professor, Department of Periodontics, Faculty of Dental Sciences, to please grace the stage. I'd like to take this opportunity to introduce our guest speaker. Ma'am was a gold medalist winner at the National Law School of India University, Bangalore in 2014 and went on to complete her Bachelor of Civic Law at Exeter College, University of Oxford. She has a long list of awards and achievements to her credit. To name a few, she's been the winner of Kumari Devi Menon Memorial Medal, the winner of the HL Gold Medal for the Best Essay in Constitutional Law, winner of the Best Written Submissions at the Stetson International Environment Law Moot, finalist at the NALSAR WIS India Pre-Moot, Hyderabad, India 2011. We are honored to have you amongst us, ma'am. You can now take over.
Dr. Sergio Matthew, the Dean, Dr. Kavita Prasad, Associate Dean, Mr. Srivara, retired IAS and also HR and legal advisor to GF, and also all the ladies and gentlemen gathered here and students. First of all, I would like to thank Dr. Sylvie Matthew and also Dr. Lalita S. Jairam, who are the scientific convener and co-convener of today's event. I deem it my opportunity to address you all today and share my insights on legal aspects that are relevant to dental professionals. So my lecture today is divided into 5 subtopics. The first topic will be generally on the right to health. As medical professionals, it's important to know that there is a fundamental right to health that is enjoined upon all citizens, and you as practitioners and service providers and also providers of healthcare services, it is important for you to know the right of the patient that you are treating. Secondly, I will speak generally on the rights of patient apart from the fundamental right to health that the state guarantees in India. Then I will move on to the duties of dentists, the regulatory regime for starting your own practice or clinical practice in India, and lastly end with the liability regime for dentists in India. So the right to health is not only a fundamental right, but it is also a human right and an inalienable right. The World Health Organization recognizes health not only as a situation where there is absence of physical disease, but also all-round social, mental and physical well-being. In India, we have the Article 21, which recognizes the right to life. There is no direct recognition of the right to health in the Indian Constitution, but through judicial interpretation, it has been recognized as part of right to life. So according to the Indian Supreme Court in a landmark decision of Consumer Education and Research Center versus Union of India, decided in 1995, the Supreme Court for the very first time read in the aspect of fundamental right to health as a part of the fundamental right to life. Therefore, right to health also enjoys the status of a fundamental right in our country today. What is relevant to dental practitioners and professionals regarding the right to health is that although fundamental rights are guaranteed by the state and it is enforceable against the state, and it's the duty of the state to provide access to timely healthcare and quality healthcare, it is important for doctors also, because the Supreme Court has recognized that it is also the obligation of every doctor or medical practitioner to extend his or her services with due expertise for protecting the life of a patient. So therefore, when you're dealing with the patient, you must remember that the patient has a right to health not just against the state but also against you. You will have to remember that you are also one of the agents through which the fundamental right to health is being recognized and guaranteed in this country. So what are the implications when right to health is recognized is nothing but also enjoining upon you certain duties towards patients who are citizens and also persons to whom you have legal rights and duties. Now I'll speak to you about the rights of patients. So you will have to remember that most of medical jurisprudence in our country evolved in the context of general medical practice, and the same has been made applicable to dentistry wherever it is relevant. There is nothing specific regarding the liability regime of dentists, but what is applicable to doctors at large is also applicable to dentists. So, speaking about the legal rights of patients, the Ministry of Health and Family Welfare, Government of India, along with National Human Rights Commission, has devised the Charter of Patient Rights, which enumerates 17 rights of patients. So, I have culled out 13 of these rights, which I feel are also applicable to dental professionals. So the first right is right to information. A patient has the right to obtain authentic information regarding their medical condition or ailment, method and options for treatment. The second one is right to records and reports. Hospital authorities and practitioners have a duty to provide medical records and reports to all patients or their caregivers. 3. Right to emergency medical care. No patient can be turned away from receiving emergency medical care from a government or a private hospital or a private practitioner. 4. Right to informed consent. A medical professional should obtain the consent of the patient or their caregiver before performing any treatment. 5. Right to confidentiality, privacy and dignity. All medical professionals have to maintain the highest level of confidentiality regarding the private details of the patient. 6. Right to second opinion. A patient is free to go for a second opinion from any doctor of his or her choice. Right to transparency in rates. All costs that are levied on patients for services, tests and treatments rendered by any medical establishment have to be made available to the public and to the patient. 8. Right to non-discrimination. Doctors and medical personnel cannot refuse treatment to patients on the ground of gender, caste, religion, race, place of birth, illness, etc. 9. Right to safety and quality care according to standards. It is the duty of medical establishments to provide a safe and clean environment for treatment. Right to choose alternative treatment options if available. Once a patient or their caregiver is informed of their treatment options, they are free to choose the course ahead. They cannot be compelled to follow a certain treatment without their will, even if the doctor deems it necessary. 11. Right to choose source for obtaining medicines and tests. When medicines or tests are prescribed to a patient, it is up to them to decide where they want to purchase it from. It is guaranteed as their right as a consumer to have access to a variety of goods and services at competitive prices. 12. Right to proper referral and transfer, which is free from perverse commercial influence. All patients have a right to receive seamless service and quality of care being upheld when a patient is referred to a different doctor or a patient is referred to a different facility. Lastly, right to patient education. Patients have the right to receive education about the facts relevant to their condition and healthy living practices. So these are some of the rights from the Charter of Patient Rights which I have read out to you today, which all dental professionals and practitioners should bear in mind while treating their patients and ensure that all these rights which the patients have been guaranteed are upheld and protected during the course of your treatment. Now I will come to specifically the duties of dentists. As all of you all know by now, the Dental Council of India is the apex regulatory body of dentists in India. The Dental Council has framed what is known as the Dentist Code of Ethics Regulation 2014. This is a comprehensive code which contains duties of dentists under various heads. I will take you briefly through the duties under each of the heads. Why this becomes important is that any breach of these duties set out in this code entails liability and also disciplinary proceedings which will have very drastic consequences. The Dental Council and also the state dental councils are empowered with considering cases regarding medical negligence, regarding breach of these duties. So suppose a patient has felt that they have not been treated properly or any of their rights have been violated, they are free to approach these dental councils for redressal. At which point in time it becomes very important for dental practitioners to know what their duties are. The first set of duties are the duties of dentists in general. Dentists shall remember that care of the patient and treatment of the disease depends on skill and prompt attention shown by him or her, and always remember that his personal reputation, professional ability, and fidelity and integrity remain his best recommendations. It is important that dental professionals treat the welfare of the patients as paramount to all other considerations. It is important that dental professionals are courteous, sympathetic, friendly and helpful and always ready to respond to calls of patients. Dental professionals should try to continuously improve medical knowledge and skills and make available to their patients and colleagues the best of professional attainments. The dental surgeon or dental practitioner should practice methods of healing founded on scientific basis and should not associate professionally with anyone who violates this principle. Every dental practitioner should maintain relevant records pertaining to his outpatient and inpatient. Every dental professional should take care to prescribe and administer drugs in a responsible manner and ensure safe and rational use of drugs. Every dental professional should ensure quality treatment that does not compromise the outcome of treatment. A dental surgeon should expose, without fear or favor, incompetent, corrupt, dishonest or unethical conduct on the part of members of the profession. The personal financial interests of a dental practitioner should not conflict with medical interests of patients. The next set of duties is regarding the duties of dental practitioners towards patients in particular. Dental practitioners should attend emergencies reporting to the clinic and mindful of the high character of his or her mission and the responsibility he discharges in the course of professional duties. A dental practitioner can refuse treatment using his discretion, but it should not be on the basis of any discrimination of color, caste, religion, nationality, presence of ailments or other contagious diseases. Confidences concerning individual life entrusted by the patient to a dental surgeon and the defects in the character of patients observed during professionally attending to a patient should never be revealed unless the revelation is required by laws of the state. The dental practitioner should neither exaggerate nor minimize the gravity of a patient's disease. The third set of duties are regarding consultation. If the patient requires expert care of a specialist, appropriate references to dental or medical professionals should be made according to the nature of the problem. It is the duty of a specialist to refer to the patient back to the original dentist after the treatment for which the referral was made. All referrals for investigation should be judicious, justifiable, and done in the best interests of the patient. All dental surgeons engaged in case should be frank with the patient and his attendants. Punctuality for consultation should be observed by all dental professionals. A dental surgeon or the clinic run by him shall clearly indicate the cost of the treatment through the procedure and make an estimate of all costs likely to be incurred beforehand. When a patient is referred to a specialist by the attending dental surgeon, a case summary of the patient should be given to the specialist, who should communicate his opinion in writing to the attending dental surgeon. No decision should restrain the attending dental surgeon from making such subsequent variations in the treatment if any unexpected change occurs, but at the next consultation, reasons for such variation should be communicated to the patient. Now, apart from having duties in general and duties towards the patient, the dental professionals also have duty to the public. Some of these duties that are highlighted in the code are dental professionals, especially those engaged in public health dentistry, should enlighten the public concerning oral health and prevention of oral diseases such as dental caries, periodontal health, precancerous lesions, and oral cancer. At all times, the dental surgeon should notify the constituted public health authorities or hospitals of every case of communicable disease under his care in accordance with the laws, rules and regulations of the health authorities. In dealing with pharmaceutical and allied healthcare industry, a dental professional shall always ensure that there shall never be any compromise either with his or her own professional autonomy and or with the autonomy and freedom of the medical institution. So apart from listing these positive duties that every dental practitioner has to follow under the code of ethics, The Dental Council also lists a bunch of unethical acts, or those are the don'ts for any dental professional. Some of them which I found relevant, which I'll share with you are: a dentist or a group of dentists may advertise provided they maintain decorum. Soliciting of patients directly or indirectly is unethical. Printing of self-photograph or any material of publicity in the letterhead or signboard of the consulting room or any clinical establishment shall be regarded as self-advertisement and unethical conduct on the part of the dentist. A dental surgeon shall not give, solicit or receive, or offer to give, solicit or receive any commission or bonus in consideration of or returning for referring, recommending or procuring any patients for dental, medical, surgical or other treatments. So these are some of the do's and don'ts that are prescribed by the Dental Council of India. These are very important because they are actionable, and if a patient finds that there is a violation of any of these duties of a dentist, he or she is free to file a complaint before the concerned Dental Council, and it will result in proceedings being initiated. So therefore it is important that each and every one of you go through these code of ethics before embarking upon any form of private practice. Now, once you are equipped with the do's and don'ts and know about the rights of patients, the other important aspect is what is the regulatory regime that governs dentists and dental clinics. So every citizen of India has the fundamental right to practice a profession of his or her own choice, provided there are some reasonable restrictions which can be imposed by the state. So firstly, your right to practice dentistry is secured as a fundamental right. The next aspect is the fact that the dentists are regulated by a regulatory body, which is the Dental Council of India. So all dentists have to begin by registering themselves with the concerned Dental Council, and only after obtaining the relevant registration can they embark upon private practice or practice their profession. Now, apart from registration and also the freedom to practice your profession, it is important to bear in mind the Clinical Establishment Registration and Regulation Act. So apart from the dentist personally being registered and being found qualified to practice dentistry, it is important that the establishment that they have is also certified and is compliant with all laws. So the Clinical Establishment Regulation Act is basically applicable to all medical professionals, including dentists. Important aspects of the Act relevant to you are firstly registration of clinical establishments. No person shall run a clinical establishment unless it is duly registered in accordance with the provisions of the Clinical Establishments Act of 2010. The Act sets out the minimum conditions that a clinical establishment must meet before it is registered. In order to get a registration, you should ensure that your clinic meets all the minimum criteria that is prescribed under the Act. It is important to ensure compliance with the Act because there are serious consequences on persons who do not comply with the same. The competent authorities under the Act are empowered to cancel the registration if there is breach of any of the conditions. However, the cancellation is not unilateral. You will be given an opportunity to voice your view. You will be heard in the matter, and only then, after considering your view, will they take a call on whether your establishment is compliant or not. Also, authorities may choose to inspect your establishment if they find that it is not being compliant. The penalty under this Act can range from a fine and also can include cancellation of the registration itself. However, it cannot be done in an arbitrary manner. The authority that is deciding whether cancellation has to be registered has to bear in mind the category, size and type of clinical establishment and local conditions of the area in which the establishment is situated. So before you embark upon establishing a clinic, it is important to note that you have secured all the permits and approvals from the necessary authorities, including under the Clinical Establishments Act. Now, what is of significance to dental practitioners is the liability regime. Now, the liability regime in India is basically nothing but the legal responsibility of a dentist for any harm or damage caused to a patient as a result of omissions or commissions. So in India, liability regime is divided into various laws. First is under tort law, second is under contract law, third is under Consumer Protection Act, and lastly there is also criminal liability. So I'll briefly enumerate on what liability can be imposed upon you under each of these regimes and also discuss the defenses that are available to dentists. So firstly, under tortious liability is nothing but medical negligence as it is popularly called. Medical negligence means liability that arises from breach of a legal duty owed by a dentist to a patient, which results in harm to a patient and is enforceable by paying monetary compensation to the patient if found guilty. Tortious liability can be two types. It can be primarily on the doctor, or it can be vicarious where the dentist is held responsible through a hospital. Now, what is the standard in order to show that there is negligence? If a patient were to complain of negligence caused by a doctor, in order to assess whether there is in fact negligence that has taken place, there is a four-pronged test. The first limb of the test is that the doctor should have owed a duty of care. Second is that the doctor did not maintain that standard. Thirdly, an injury resulted from lack of care. And lastly, there is a connection between the negligent act and the resultant injury. So only when all these four elements are proved can a doctor be held for negligence. Also, the court will also take into consideration the defenses that a doctor has when in a case of negligence. I'll come to those defenses. In order to determine whether there is negligence or not, the test evolved in UK. It was known as the Bolam test, and the Bolam test is used in India and formulated in the following manner. A doctor is not guilty of negligence if he or she has acted in accordance with the practice accepted as proper by a responsible body of medical men skilled in that particular art. Putting it the other way around, a man is not negligent if he is acting in accordance with such practice merely because there is a body of opinion who would take a contrary view. Practically, this means that when there is a case of medical negligence for adjudication, the test is to compare whether the doctor in question against whom there has been a complaint has acted as a reasonable person or a reasonable doctor of that skill would have acted. It means that you don't have to satisfy a very high degree of skill, or you don't have to show that if there was a better way to do this. As long as you've done it with reasonable care, then you can be exonerated from negligence. Suppose the tort of negligence has been proved, then the doctor will be liable for monetary compensation to the plaintiff, who is the patient. The second is the Consumer Protection Act. So although tortious liability evolved under common law, it has been recognized under statute in India under the Consumer Protection Act. In the judgment of V.P. Shanta versus Indian Medical Association, the Supreme Court has held that all medical professionals, which includes dentists, are covered by the Consumer Protection Act. Therefore, the patient is recognized as a consumer and the dentist is recognized as a service provider under the Consumer Protection Act. The Consumer Protection Act operates at different forums, first at the district level, then at the state level, and then at the national level. From the National Consumer Disputes Resolution Forum, the appeals go directly to the Supreme Court. So therefore, since consumer protection also recognizes liability of doctors, the elements of negligence are also recognized under consumer protection law. So a patient may invoke the Consumer Protection Act to make a complaint of negligence regarding the doctor, and depending on the tests that I just read, if those tests are met, then the court will come to the conclusion that there has been negligence or not on the part of the doctor. The Consumer Protection Act initially provided only for monetary compensation, but in 2019 there was a major overhaul of the legislation, and now all the directions and orders of the Consumer Protection Act also entail criminal liability if not adhered to. Then the next aspect of liability is contractual liability. If there is a contract between the dentist and the patient, and there is any breach of that contract, the patient as a contracting party can sue you for breach of contract. Lastly, and the most dangerous one, is criminal liability. Criminal liability is dangerous because all the previous forms of liability end only in monetary compensation, but criminal liability results in incarceration or going to prison, and therefore it is very important to ensure that criminal liability cases don't arise, and if they arise, that they are effectively defended. Now, what are some of the offences that dentists can be held liable under the Indian Penal Code? First is Section 304A, negligent homicide, a rash or negligent act resulting in death of the patient. Section 336, an act endangering the life of a person. Section 337, a rash or negligent act causing simple injury. 338, a rash or negligent act resulting in grievous injury. So, under either of the sections, a patient may proceed against the dentist, and this will entail criminal liability. Now, what are some of the defences available to dentists? If these are the forums available for the patients to voice their grievances, is there any defence available to the dentist? So, the first is contributory negligence. If the patient has also contributed to their own injury, then to that extent the liability of the doctor is reduced. Secondly, assumption of risk. If the patient, knowing fully well the risk associated with the treatment and also has consented to the same and has given informed consent, then the liability of the doctor proportionately reduces. Lack of causation. If between the injury that is caused to the patient and your treatment, there is some other intervening factor, then it is not directly linked to your treatment, as a result of which you can be exonerated. Then it is also important to remember that if the dentist has acted with reasonable skill and diligence, as expected of an ordinary dentist, that is more than sufficient. Then the other defense is that a difference of opinion is not negligence. A dentist cannot be held liable simply because another dentist with greater skill would have acted differently, so long as the dentist in question has shown reasonable skill and diligence. The other defense available is that an error of judgment is not negligence. And lastly, if the outcome of the treatment which resulted in injury was a pure accident, even in these cases, the dentist cannot be held liable. Under criminal law, one of the most important defenses is the lack of intent, that the dentist never actually intended to commit the crime, apart from all these other defenses that I have mentioned. So the next question is, apart from having these defenses, suppose a dentist were to be held liable, how do they protect themselves? So one way that they can do so is to obtain professional indemnity insurance, where they are protected from the consequences of any legal proceedings. It could either be the cost of defending the proceeding or the monetary claim itself that is imposed. Similarly, there is the medical establishment's professional negligence, errors and omissions insurance policy, which hospitals and institutions may avail in order to protect their liability in the case of any form of liability that is foisted on them or the doctors. This is the existing regime in India for medical negligence, which is most relevant to dental professionals. Now, as all of you all have now heard in today's session and also perhaps across sessions in this conference, AI has a huge role in practice of dentistry. So the question then arises is, what is the role of dentist if there is any injury caused to the patient because of AI? So actually there is no answer to this question because the advent of AI itself is so nascent. There is not yet any case in India where AI has been held responsible or a dentist using AI has been held responsible for any injury that is caused. Some of the views in the field are that they should treat the AI itself as the doctor because most of the liability regime is focused on humans. But if AI is to be treated as a doctor, whether personhood can be attributed to AI, which is nothing but an algorithm, that is one question. The second is the regulatory regime for using AI, whether AI that is used in dentistry should be subjected to greater certification to ensure that there are fewer errors. In India, except one amendment regarding medical devices and their certification, there is nothing specific regarding liability that arises due to usage of AI. That is one of the areas which both lawyers and dentists have to look forward to in the coming years to see how the liability regime evolves. So with these few words, I'd like to end my speech today. I'd like to thank the organizers for giving me an opportunity to address each one of you. And I thank the audience for your attention.
Pointers. These are things we all should know but hardly do. And it makes us so proud to see such a young achiever, especially when the bond is so close to our RUAS family. I request our chairpersons to share their views on the talk.
Namaste, madam. So, I have my grateful thanks to Nayanthara. I don't know whether the value of her speech is appreciated by the audience. As far as a legal person, I have gone through many literature, the YouTubes, the artificial intelligence notes, so on and so forth. The notes our young Nayanthara did is something exemplary. Please remember, it is one of the best legal speeches I have heard regarding this subject. So I remember our mother is the Honorable Justice of the Supreme Court of India and father is our illustrious Gopal Krishna. I want to see her to be the justice like her mother, and I would like to live for that day. And she richly deserves it. See, I think she has covered each and every aspect of the, it's a very, very difficult subject. The medico-legal cases. See, every serious profession has some, it is intertwined with some professional hazard. You cannot escape it. Whatever may be your intention, whatever may be your expertise, you are likely to get into some slips like this. Of course, the learned advocate like Nayanthara will be there to help you. But then, the whole speech, I request all the students particularly to go through again and again. And I request the organizers to make it available to every participant here. And this is my preliminary remarks regarding our speech.
Thank you, sir.
Thank you, Advocate Nayanthara, for that wonderful talk on the medico-legal jurisprudence, which is the need of the hour. Because many of the times in most of the institutions, we press upon these issues and we speak about the importance of informed consent and how you have to treat your patients in the clinical setup, etc. And even when such things are taught at institutions, we really do not know the legal aspects. And today we have had a in-depth knowledge what is being given by Ms. Nayanthara, and especially about the duties of the dentist and also the liabilities and how we can defend ourselves. That was the most important thing of the present day talk, because we do not know how to defend ourselves when someone sues us and when we are in the opposite side. And we know that patients sue the medical professionals in Western countries very easily, and I think that trend is following in the present Indian scenario also. So we should be quite aware of the legal aspects, and we should know as citizen of India like what rights we do have as dentists and what we should give back to the society also. Thank you for that wonderful lecture. Thank you.
I now request our chairpersons to present the guest speaker with a token of appreciation. I request Mr. Gopalakrishna sir to kindly present the certificate of appreciation to our chairpersons. Thank you, sir. We are now at the last segment of the scientific session, and that is the final round of the quiz. So I hand over the dais to Dr. Dhananjay, sir.
Jagrati and team from Maruti Dental College, Team 2 Adarsh and team from FDS, Team 3 Lasya and team from M-Cards, Team 4 Naren and team from Danan Sagar, Nazreen sorry. Team 5 is Sanjay and team from FDS. The last team is Zuhair and team from FDS. Your team names.
We are Team Pinkham. I'm Dr. Harshita. This is Dr. Satya and she's Dr. Jagrati. We are from Maruti Dental College.
Team 2.
We're Team White because the three of us coincidentally wore white today. We are final year BDS students, and our subject that we've liked the most so far is oral path. So hopefully we have some oral path questions today. I'm Yukta, Adarsh.
Good afternoon, everybody. We are Team Jasper Jumper, and we are from MCOD's Manipal. I'm Dr. Lasya, she's Dr. Gauri, and she's Dr. Khushbu.
Hi everyone, we are Team GV Black. I am Amreen, this is Nishita and Priya.
Hi, we are Team Super Dents. So I'm Sanjay, this is Kirtan, and this is Subramanya. So we are from the BDS FDS.
Hello everyone. So we are Team OPGs. It's not only orthopantogram, but it's also the oral pad gangsters. So this is Bhavna Dama, this is Dr. Zuhair Bergami, and Jeevit Joseph.
Thank you. So first I'll tell the rules and regulations. We have kept it, what I call it as KISS, that is, keep it simple and silly. Okay, so as you all know, we have 6 teams and 6 rounds. And participants, please note that you have only 10 seconds for each question. And you can't change your answer. Only one answer is allowed. And here, there is no passing of questions. There is no confusion. There is no passing of questions. No negative marking. We wanted to introduce an elimination round, but since few of you will be good in academics, few of you may be good in history, something like that. So we didn't want to. So we wanted to give a fair chance to everyone. So there is no elimination. You don't have to worry about elimination and negative marking. And your quiz consists of 6 rounds. That is 2 rounds of academics. 1 is logo round. 1 is history round. 1 is celebrity round. And the last one is the sports round. And for the audience, please don't prompt. Okay, if the participant does not answer, the question will come to you only. Please don't prompt. Okay? And anyway, you will be rewarded for each correct answer. And PWPGs are not allowed to answer. And please don't prompt, especially second years. Don't prompt your friends also. Okay? So the first round, we'll start with the academics round. Over to Dr. Indresh. Now round 1 is academics. Now, one more thing, we have Dr. Yom keeping up the scores and the time.
Good afternoon all. Very nice to see that many of the finalists are from FDS group. All the best to all of you. It is going to be very simple and it's all straightforward answers. So shall we start? We'll be starting from team 1 because they have got the fair chance of getting the highest marks in the prelims. So the first question.
Vyom, are you ready with the time?
Yeah. The first question for team 1 is, during composite restoration, photopolymerization stress buildup can be reduced by
incremental technique.
Sorry, that's a wrong answer. Anyone from the audience? Not the staff. Not the staff.
Anyone wants to answer can raise their hand.
Dr. Grishma. No.
See, the question is direct, photopolymerization. So it's about curing. How do you modify that? That's all. It looks a little complicated when you're reading.
Let's go with the answer.
The answer is soft start polymerization. This technique actually allows a slow initial polymerization and high stress relaxation during early stages and ends at the maximum intensity. Without wasting much time, let's go to the second question to team 2. Wickham stray is seen in
oral submucous fibrosis.
Or a lichen planus.
Answer we'll take for the first one. There is a wrong answer. So
somebody has answered here already. The answer is lichen planus. So the teams are ready to open the score.
The third question. Let's go to the team 3. The muscle group that opposes buccinator's mechanism is.
Yeah, anybody from the audience? Somebody's raising their hands. Huh? No.
The answer is muscles of the tongue. Okay. Now the next question to the team 4. Then you please pass on the mic there only. The Dentist Act in India was introduced in which year? Please, these are very important.
Please listen to them. Your time is up.
1982.
Oh, wrong answer.
Wrong answer. Audience? 19?
Yes.
48. Who was it? You can come and collect chocolate. Okay, the answer is 1948.
And it was adapted as a law into the Constitution in 1956. So the fifth question is, the skull at birth contains dash number of separate bones. Team 5. Time's up.
Audience? Understand the question is number of separate bones.
Not the fused ones. The answer is 45 separate bones are present and they later fuse on to become 22 bones. The final question, that is sixth question for team 6. Strawberry tongue is clinical feature of what? Your time is up. So,
everybody from the audience? Yes, Scarlet Fever is the right answer. So the interns who are preparing for the entrance exam, they know this.
You're all doing good with your entrance preparation here. Very good. Okay, we move on to the team 1 again. From team 2, we'll continue.
The second round of academics. Sorry. This is the question for the audience, right? Question for the audience. Hey, where the wallet is? Give only one more. Yes, it's the right answer. And one more question for the audience.
Regarding the teeth arrangement for complete denture, spherical theory was proposed by?
Any Prosto PGs here? Prosto PGs? Monsoonker. Yes, it's the right answer.
Monsoon proposed it. We'll go on to the next round.
Okay.
Team 2 will start the...
So till now, no team has opened their account.
All are at 0 now, all the 6 teams.
Yeah.
So all the best for this round. Cyst arising from the rest of molasses is called as? Your time is up.
Time is up. Audience?
The answer is correct. Radicular cyst.
I think you should have been here. Anyways.
The second question is to team 3. The predominant immunoglobulin present in cellular fluid. Please don't answer in the audience.
IG.
IG is the wrong answer. IgG is the right answer. IG is in the saliva.
IgG is the right answer. Now, the question for team 4. Teeth that erupt within the first 30 days of birth are called? That's the correct answer. The first ones to open the account.
Team 4.
And for team 5, the question is degeneration of periodontal tissue without inflammation is called? Your time is up.
Audience?
Audience?
Anybody other than that group?
Other than Sai Kalyan and his team.
What is it? Yeah, periodontitis is the correct answer.
That's the right answer. Now, for Bhavna and team, the question is, halitosis is primarily because of dash compounds.
Sulfur.
We will give it to you.
Yes. Sulfide compounds. We'll give that to you. Volatile sulfide compounds like hydrogen sulfide and dimethyl sulfide are the reason that you get that bad smell. Now, the last question to the team 1. When dental burr is sterilized by autoclaving, which chemical is used for protection of the burr?
Nobody is raising their hands. Time is up. Audience, staff. 2% sodium nitrate because it's an anti-rust agent. Now, a few questions for the audience. The primary constituent of porcelain is feldspar. Yes. Where are the chocolates? Yeah. Feldspar is the right answer. Porcelain based on feldspar are called as feldspathic porcelains. Okay. In Ellis classification of trauma to anterior teeth, class 4 represents. Oh, great. Yeah. Okay, now go to Dr. Shivaranjali. We'll start with the logo round. At the end of round 2, we have group 4 and group 6 with 10 points each. Me too. What up now? Start from team 3.
Very good afternoon, all of you. So this is about the logo round, and I think you must be exposed to the materials that you're working in the clinic, right? So you must be thinking about how they have come all along. They must be exposed to the materials in your clinics, right? So you must be thinking how they were researched and developed, marketed and distributed so that we are using right now. So this round is basically in identifying the logo of a company. Okay? So we will start with team 3, which is Jasper Jumper. So again, 10 seconds will be given for each of you. Can you identify the logo of the company? Yeah, time is up.
Audience.
For the audience? Very good.
Ivoclar is the right answer.
So, for those of you, Ivoclar actually was from Switzerland. Later they moved on to a small microstate, German-speaking state that is Liechtenstein. And Ivoclar is very famous for our ceramics. So the next question goes to team 4, which is black team. Identify the company? No. Yes. Audience must not.
Wrong answer.
Yeah, time is up. Now the audience can. Yeah, very good. So, Colgate is an American brand company, and it started in 1873.
Audience, please don't wait for your turn.
Yeah, you will get your turn, audience, so please wait. So this is for the team 5, which is super dense. No, please, no murmuring. Yeah.
ESP 10.
The wrong answer. Audience.
Yeah. So DENTCON actually it's a US company, and then they had a merger with Germany, and that's why it's called DENTCON Sirona. Sirona Dental Systems is from Germany. Okay. So next goes to the team 6 OPGs. Yes.
This you
should be
using it.
10.
Time up.
Time up?
Audience.
Yes, very good. So GC is basically a Japanese company based in Tokyo, which was developed by the chemists. And zinc phosphate was one of the first products that they had developed. So the next team 1, right? So this is pink cap.
Why don't you come here? Jumping to answer. Time up. Sorry.
Nobel Biocare is the right answer.
Right answer from the staff, Nobel Biocare.
So it is a Swedish company developed by Brainmark. So they had a collaboration with Bofors company to further develop the implants. Okay, so the next is the team 2, right? So team 2 is white.
Audience? Anybody from the staff? Anybody from the staff?
Yeah, Storman from Switzerland again. So first they ventured into orthopedic implants and slowly they expanded to dental implants. So the next team is team done. So we are done with the logo round.
The moral of the story is, tomorrow before starting using any instrument or any cement, please look into the logos. Now for the audience, few questions. Yesterday you have been listening to digitization, digital dentistry, digitization dentistry so much. Staff? Oh, somebody's... Huh? Very good.
Very good.
Who was it?
Very good. Paromita, I think.
It's 3 shape. Next. This orthodontist should be able to answer. Invisalign. Now we'll go to the history round.
Okay, so we'll go with the fourth round. Yeah. So we'll go with the history round, and it is mostly on trivia. But history, when we look at history, it makes us realize where we are right now, and it is because of their endeavors that so far we have come today. Okay, so
if you have listened to yesterday's talk by Dr. Major Jayan, you will answer all the questions. So that was the importance of attending the conference and lectures. Now we'll start with team 4.
JV Black, right? So this is a picture of the first dental implant which has been done in 1937. Can you identify the material the implant is made of? Bamboo.
Wrong answer. Audience.
To the audience.
So all of you are weak in history. Staff? Huh?
Yeah, so Italium. Cobalt chrome is known for its better flexural strength actually than stainless steel or titanium. So it was the first one which they introduced for dental implants. Okay, so we will go for the team 5, super dense. This is a picture of the first dental chair in 1790. Can you name the dentist who made this chair?
This was told by Dr. Jain yesterday.
And this is quite inventive actually. I'll tell you why.
Audience? Nobody.
So this was by Joseph Flagg. Why I said inventive? Because he modified our existing chair. He just added a headrest and an arm extension. Okay? Yeah. So the next is the team 6, this OPGs. So this is a picture of an ancient dental practice followed during Indus Valley civilization. Can you name the drills used?
One of the first slide, Dr. Jain.
And this is very quite indigenous actually. So those days they tried to solve a problem using the tools that they had. Yeah, name the, you should name the drills. I'm almost giving you time up.
Anybody from the audience?
Time up.
See the first picture.
There's a clue in the picture itself. They used a bow. Actually, bow was actually used to make a flame also those days.
Bow drills.
So those are bow drills. So okay, so the next is the team 1, which is Pickham team. So picture of a dental cosmetic trend which was popular among Japanese women in 2011. Can you name the trend? Looking at
recently. Look at the canines.
Audience?
Audience?
Yeah, vampire, but they didn't name it as a vampire kind.
What is the technical name?
Yes, who's that?
Who was that?
That's right. Right answer. It's a
Very
snaggle
good.
food. Snaggle means something irregular. So this was a trend among Japanese women back in 2011. So next is the team 2, that is the whites. This is a picture of oldest dental foot engine invented by Dr. John Greenwood. Name the household instrument he used for the dental foot engine.
Look at the picture properly, you'll be able to answer. Wheel. Audience? Sewing machine, yeah. Partly right. Spinning wheel.
Okay, so we'll go to team 3, that is Jasper Jumper. Yeah. This is a picture of the oldest theory of tooth disease by Sumerians. Can you name the theory? Yeah, timer. Yeah.
Audience? Worm theory. Now for the audience, this is a picture of the oldest toothbrush. Name the country of origin. China. Identify one of the oldest dental machine invented by William Stager. Orthodontist. The casting machine, one of the first casting machine. This interesting trivia. Identify the denture owned by famous politician. Winston Churchill or a RPD. Is a denture. No, much older than that. Much older than that. George Washington. So look at the material they've used. Hippopotamus teeth, bone, human teeth and brass weights, and also they use some rigid gold wires to stabilize the teeth. This is a picture of one of the first ancient book of dentistry in 1350. And it's very difficult, that's why I kept it for the audience. It's little medicine book of all kinds of disease and infirmities of the teeth. Written by Hans Bushling. Okay, now it's interesting round. This is interesting round, and now it's time to get some points because day in and out you are on the social media using the phone. Let me see how many of you answered. How many of you answer these questions? Team 5. Identify the American author and dentist. Riders of the Purple Seas is his best-selling book. He's a famous author. Anybody from the audience? Zane Grey is the right answer. Who was it? Zane Grey is the right answer. His name was Pearl Zane Grey, popularly known as Zane Grey. He was from Ohio State. He passed out as graduated from University of Pennsylvania. Next. Yeah. Audience, please. Identify this.
Audience. Wait till the team is done.
Identify this pan-Indian actress once known as the crush of India on social media.
You should answer quickly. Last 5 seconds.
I'll throw you out.
Rashmika Mandana.
Yes, the right answer is Rashmika Mandana. This scene is from Orisu, which was released last month. Okay? Now, the question is for this team. Give the mic. Give the mic. Yeah, identify this American gambler, gunfighter, dentist who was diagnosed with TB at an early age. In fact, I can tell he was infamous or notorious. The picture is not very clear. Anybody from the audience? His name associated with leave. Leave from work. Dog holiday. Yes, is the right answer. Dog holiday. He graduated from University of Pennsylvania and he was known for his skills with gun and cards. Next. Team 2. Yeah, name this Grammy Award winner dentist and environmentalist based in Bangalore. Recently won one more Grammy Award. Please, audience, you'll get a chance. Don't know him. Known for his Earth song. Yes, audience. Ricky Cage. Ricky Cage is the right answer. He graduated from Oxford Dental College and is famous for his Earth song. Next. Team 3. Name this South Indian actress who happens to be a daughter of prosthodontist but unfortunately discontinued her studies of it. And her teacher is here in this auditorium. You not watch Kannada movies, Telugu movies? It's time to watch. Yeah. Aindrata Ray. Where is Suma madam? Ma'am, you please get up. Suma madam was a teacher. I don't know whether she was scared of her. She was scared of Suma madam. She left dentistry. Okay. Our father was Dr. A.K. Ray. I had the opportunity to work with him when I graduated. Okay, dropped out from third year from the MRI Dental College. Okay. Next. You're done, right? Yeah, team 4. Name this Colombian and United States model and actress but who discontinued her dental studies to become a model. The clue is she rose to popularity when she appeared in a Diet Pepsi ad with David Beckham. We'll have one more quiz for you. Yeah. Sofia Margarita Vergara. She was known for his movies like Mashed Kills and Hot Pursuit, etc. Next. Which team is that? The last team. Your team is there. Done. Okay. So this is for the audience. Identify this dentist who is known as singing dentist. During the COVID times, his videos went viral on social media. Huh? What? Yeah, Dr. Milad. Dr. Milad Shadru. His Instagram handle is at singing dentist. Okay, next again for the audience. Identify this prosthodontist as present MLA. No, one answer from the staff. Dr. Bharat Shetty is MLA from Bangalore North and former principal of AJ Shetty Dental College. Next, again for the audience. Identify this Egyptian author and a dentist. He's still alive. He's an oral medicine and radiologist. Who? Rakesha. Is Alan Al-Aswani. Aswani and is more known for his second book, that is Jacobian Building, Chicago. Yeah, last question. Identify this prosthodontist turned politician. It is Sudhakar. He is former MLA from Chintamani. Guys, it's high time you start following all these people, okay? Now, the last round. Yeah.
Okay, so we'll just have an update on the scores. Group 6 is leading with 20 points. And Group 4 having 10 points. And the other groups have yet to open the account.
Today the winners will be the audience. Okay. For the group 6. Identify the sports celebrity who is undergoing dental treatment by his former Ranji cricket teammate who happens to be a prosthodontist. Look at the picture properly. Come, replace the team.
VVS Lakshman.
Yeah, the answer is VVS Lakshman. And the person on is Dr. Partha Sarthi. They were Ranji teammates. And Partha Sarthi passed out, graduated from SDM. SDM Dharwad. Huh? Satwalkar, okay, sorry. Yeah. And this picture was posted by VVS Lakshman after he finished his treatment. Okay. Sure. Okay, next. Team 1. Identify this famous celebrity with the braces. Sports celebrity. Footballer. Yes, audience. Yes, it's Neymar Jr. Present captain of the Brazilian national football team. Now group 2. Okay, name this famous middle order batter posing with the braces.
Jamia Rodriguez.
Yes, we'll give it to you. It's Jamima Rodriguez. The middle order batter for the Indian cricket team, now batter for the Delhi Capitals women's IPL team. Next. Identify this international cricketer who lost his anterior teeth while attempting a catch during one of his Premier League match, and that was the statement on the Instagram what he gave. Lost 4 teeth, got them back, got 30 stitches, and he can still smile. I'll be back, I'll come back stronger and whatever. He's a Sri Lankan cricketer. And don't know. Yes? Chamika, right. Chamika Karunaratne, and one more trivia is he's also a national champion in javelin throw. Okay. Next, team 4. Identify the sports person with the missing premolars. I know you all know this answer, please let them answer. You get a chance. Time up. Playing for RCB and now playing for RR. And is well known on social media because of his dances with his wife, Danya. Wife is a dentist, yeah, wife is a dentist. Yeah, one more connection. Yes, team 5. Wait. Anybody can answer this. Okay, he is Anil Kumble. But I want to know in which place did he break his jaw? Which venue?
West Indies.
Venue, West Indies, right. Sorry? Anybody in the audience? It's on Antigua in 2002. And the bowler was Melvin Dillon. Can somebody name the oral surgeon, the dentist who treated him? India should be knowing. Kishore Naik. Yes. Next. Done? Okay, that's the end of the quiz. By the time they calculate the points, question for the audience. Identify the sports person with missing premolars. Why I posted this is, both the players, they have a lot of money. I don't know why they're not going for implants or something else. It's high time, we bring some awareness among them. Okay, it was MS Dhoni. Next. Yeah, this photo I insisted on my son. Okay, he wanted this question to be included. Identify this Indian middle order batter who was hit on his lower jaw and had to be taken to hospital immediately. If anybody has watched this 83 movie recently, can answer this question. Yeah, it was Dilip Engsarkar. And his bat was in the air, he was in the air. And after this, he was ruled out for the tournament. And the bowler was Malcolm Marshall. That's all. Yeah, I would like to thank my PGs who helped me in this PPT. Thank you. So, the winners of Group 6 with 30 points. And second prize will be shared by 2 teams, that is Group 4 and Group 2. With 10 points each. Thank you. Hope you had a good time. I finished in half an hour.
What a fantastic end to the DENTCON 2023, the scientific sessions. Can we have another round of applause, please? I request Dr. Sejal ma'am to kindly come on the stage to give a certificate of appreciation to the quiz team. Dr. Dhananjay sir. Dr. Indresh sir. Dr. Shivaranjani ma'am. And Dr. Baba Shankar sir. Kindly remain seated. We are now going to start with the valedictory program. Thank you.
Valedictory function, I request you all to please stand up for the Ramayana anthem.
ಕನಸಿನ ಸಾಮ್ರಾಜ್ಯವಿದು ಕ್ಷೇತ್ರವಿದು ಪ್ರತಿ ಕಲಿಮೆಯ ಸಾಧನೆ ಮಾಡಲು ಸ್ಫೂರ್ತಿಯ ಕೇಂದ್ರವಿದು ಅಜ್ಞಾನದ ಕತ್ತಲೆ ನೀಗುವ ಸುಜ್ಞಾನದ ಸೂರ್ಯನ ರಶ್ಮಿಗೂ
Good afternoon, ladies and gentlemen. Was a fantabulous scientific deliberation that took place in the past 3 days. These 3 days have been hectic, full of activities. You have hands-on poster presentations, scientific paper presentations, guest lectures, and I'm sure many of the young minds present here among us know that there is more to dentistry. There is more to treatment planning. There is more to material science than what we regularly use. All this went without any chaos, effortlessly and smoothly, because of constant involvement in all aspects by the faculty members and the student team of FDS. Thank you for making DENTCON 2023 such a wonderful success. We call upon the dais, the faces behind this successful mega event. I would like to first call upon the organizing chairman, our dean, Dr. Siljo Matthews, whose vision of this undergraduate conference has been conceived and nurtured for many months, which finally stands here proudly accomplishing its goal. We now call upon the silent force behind this extravaganza, who constantly encourages students to be a part of this event, Dr. Kavita Prasad Ma'am, our organizing secretary. One of the most important aspects of any conference is the scientific session. It's more so the heart and the soul of a conference, enlightening our minds for the betterment of mankind. Leading the scientific session is our ever so efficient Dr. Sylvia Matthew and her super efficient team. We request Dr. Sylvia Ma'am to please grace the dais. All this requires a lot of logistics, preparation, last-minute requirements, so that the event goes on without any hiccups. Thanks to Dr. Prashant, the treasurer, for careful planning and execution. Sir, kindly grace the dais. The need for the hour in this country currently is NEP, so much talked about and debated. As our chief guest rightfully said, that the need for this hour presently is oral health policies, especially in rural areas. Who else can present this forum better than Dr. Pushpanjali, our National Oral Health Committee Chairperson. Ma'am, please can you grace the dais? The head of the reception committee, Dr. Sharanya, and her team have worked tirelessly with a smile to make this conference, DENTCON 2023, such a success. Dr. Sharanya, please grace the dais. The registration committee has done a commendable job by getting more than 600 registrations, arranging the kits, ensuring no confusion in any events. Thanks to Dr. Roshan and his team for such an awesome job. Dr. Roshan. No conference is successful without good hospitality, because it is important to please the stomach so that you enrich the brain. And as usual, it was wonderfully executed by our own administrative officer, Mr. Gopalakrishna sir, and his team. Sir, please. Transport and accommodation for speakers and delegates was done hassle-free due to the efficient work done by Dr. Pawan and his team. Dr. Pawan, please grace the dais. As dentists, we all know how important practice management is and its legal implications. I call upon our team members, Dr. Mahantesh and Dr. Lavanya, to please grace the dais. One of the most happening and successful programs in RUAS, FDS is cadaver training. We thank the management immensely for providing us the required facilities for the same. And of course, Dr. Rangnath and his team for conducting this program successfully for many years. Sir, kindly grace the dais. Laser is really a blessing in disguise. Bloodless, clean, less complication, faster recovery. We would like to call upon the dais Dr. Kranti for the laser committee for such a wonderful hands-on experience provided. Sir is also in charge of the alumni committee, and he made sure that as many of his students were present for DENTCON 2023 and shared their knowledge in various fields to our young budding dentists. Aesthetics and endodontics is the first sought out dental treatment. A smile matters a lot. It speaks many words. The workshop was meticulously conducted by Dr. Swaroop Hegde and team. Sir, please grace the dais. Implantology and digital dentistry is the need for R, as evolution and innovation is important for futuristic practices. We call upon Dr. Ravi Shankar sir for conducting a program so wonderfully. Sir. Students are key to success. When you do well, we as teachers and institute are really proud of you all. You all encourage us to do better. We call upon Dr. Dominic for coordinating with the students and motivating them to be a part of this event. A very much deserved applause, I must say. All work, no play. It never happens in FDS. So we have something to tickle our brains with quiz, which you just witnessed. So we call upon the quiz committee head, Dr. Dhananjay, for conducting this event. Last but not the least, a go-to man for any kind of technical issues. Literally anything. Any gadget that doesn't work suddenly, magically becomes all right in his presence. Mr. Anthony, head of the technical team. This event would not be successful if not for the special mention of people behind the scenes, the event management for their support, stage, sound, light and branding done by Mr. Sharath, Rajiv and Prashant and their technical help. Thank you so much. Ladies and gentlemen, a big round of applause to everybody present on the dais. It was their effort that made this a mega successful event. Thank you. I now call upon our Dean Sir, Dr. Siljo Matthew, to share his thoughts on DENTCON 2023.
Thank you, Dr. Harshita. Good evening, one and all. All good things come to an end, and the last 3 days has been a wonderful roller coaster experience for each one of us. I think it's been 3 days of learning. There was scientific activity, there was cultural activities, there was involvement of everybody in terms of leadership, learning, interacting, interpersonal interactions, and it was a whole host of experiences that everybody enjoyed. I mean, organizing an event of this nature requires a lot of effort, and I must say that I did the least. It was the team that worked behind the scenes. I think each committee chairman, the members, they really worked really hard. Now, if I have to name the names behind each committee, I think let me start with the reception committee, which was led by Dr. Sharanya. I think no words are enough to appreciate the effort she has put. Being a lady, she was there 24 hours. I mean, I have never seen someone work so hard. She was there late in the night on the first day, organizing the whole hoardings and the entire drop downs, the standees, the vertical drop downs. She personally supervised, stood there till late in the night and got everything done. I think, plus she was also in charge of the inaugural function. In the middle of all that, she came and did the emceeing for the inaugural function also. I was amazed at the kind of energy she has. and the way she has delivered beyond expectation. So I really appreciate your effort. Thank you so much. Next is the registration committee led by Dr. Roshan. I think he has been meticulous, diligent, organizing, getting the registration done on the website, and every day coming and updating everybody as to what is the status of the registration and setting panic among us as saying we need to do much more because registrations are less. So I think the kind of passion, the involvement and the sincerity that he brings is something to be appreciated. And it's a learning experience for everybody. He gave his 100%. We really appreciate that effort that he has done. I think the real hidden hand behind this event is the committee of the hospitality, led by Shri Gopal Krishna sir. I think his hand should be felt everywhere. The certificates, mementos, bouquets, the flowers, the decorations, or for that matter, hospitality, the 3 days of wonderful food that he had, everything is taken care of behind. I mean, I just had to tell him this is to be done. He will smile and say it will be done. And it is not only just done, it is done so efficiently that, there is absolutely no response from his side saying that there is an issue here, there is a challenge there, nothing. He just takes it upon himself and gets it done. That is the kind of commitment he has. And we are so lucky to have him among us because he is the man behind the show and he is a real pillar on which we depend on. Next is the Transportation Committee. Dr. Pawan, thank you so much for taking over the responsibility of getting the guests as well as the speakers to the venue. I think your duties are still not over because one of the guests is leaving on Sunday, so you'll have to drop them back to the airport. So thank you so much for your effort. Next is Dr. Mahantesh, who's in charge of the workshop, another lecture on practice management. I think I thank him for his efforts. He himself being a leader in practice management, he could get one of the leading practitioner, Dr. Jagdish, to share his thoughts. Next is the Alumni Committee, Dr. Kranti. I think he has really worked with the alumni. I had given him all the responsibility. He contacted all the alumni and made sure he had maximum attendance from the alumni, and especially the alumni evening that we had was so wonderfully organized by him. I thank Dr. Kranti for that. I think we need to take a round of applause for connecting to people of the past and bringing them today to the venue for the conference and cajoling them to participate not only as a delegate but also sharing the knowledge through scientific sessions. Thank you so much. And I thank Dr. Surup also for selecting the menu for the alumni dinner. Both of you all work together as a team. Next is the various committees of the workshop. Dr. Sarup, I thank him for organizing the workshop on Rotary Endodontics. It was sold out and for all your support organizing this event. Dr. Ravi Shankar for organizing the implantology workshop. For getting those resource persons. Next is the wonderful interactive panel discussion we had. I think Dr. Rakesh has put a lot of effort for that. I think he's not here. Yeah, I would like to thank him for getting all the top guys from Bangalore together in the panel discussion. And it was a very, very fruitful discussion and also very interactive one. We had to actually stop it because there were so many questions after the discussion. Next is, of course, the guy who got the maximum applause, Dr. Dominic. Working behind the scenes, getting in touch with all the students, making sure they are there, and also organizing the workshop along with Dr. Swamya and the team. Akshita, I think they all organized the workshop on forensic odontology. Thank you so much. I think the contributions of Dr. Dominic has been immense. I think he has been really silent behind the scene. I think the brochure, the wonderful brochure that we had he had contributed. In fact, he is the one who is responsible for interacting with the students and the various people from various faculties, especially pharmacy, and getting it done. I've been bugging him with the brochure. Every time he comes with brochure, I tell him a change. The brochure must have gone through hundreds of changes, and every time he silently accepted it, got it done. So that's Dominic for you. Thank Dr. Lavanya for organizing the jurisprudence workshop and being there everywhere, monitoring the students and taking care of the students. Thank you, Dr. Lavanya. Finally, I come to a man who was never visible at the venue, but he was the man controlling the show, making sure the students are attending and communicating all the information that I would want the students to know through him, through various social medias, and I believe he has been very strict, and that's the reason we have good attendance here for all the 3 days. One and only Anthony. And he's always smiling. You never see him serious, always smiling. Even when he scores, he's smiling. Thank you, Anthony, for all the technical support. On the day one, the whole auditorium, I had told him that it had to be spruced up, and he took the responsibility upon himself to get everything organized. He arranged for all the audio visual and everything. He directed the way it had to be done, and tirelessly, seamlessly has put 100% effort. I really appreciate your effort for that, and I really love the way you danced during the banquet. Next, I would like to also appreciate the contribution of the event management people, the +1 the event management group. I think you have been very efficient in organizing the event. I think whatever we have told you, you have done it as per our request. And you were so efficient that any corrections, any modifications we wanted on all these vertical standings that we got it done immediately. The response was so instant that, it speaks of your efficiency. You've done a wonderful job, and we really appreciate that. I think now we come to various other staff members who were part of the various committees. Dr. Purnima, I think as a scientific committee, always bubbling and organizing. She would always anticipate what is to be done, and she would do it. In fact, she would have at least made about 100 scientific schedules. Every time it was kept on changing, she kept on doing it. So thank you so much. Thank Dr. Shivranjani for your quiz contribution. And I would also like to thank Dr. Suma for taking care of the guest, the chief guest, and the guest of honor. Thank you for visiting on my behalf to the office of the DME, and we were inviting them and making sure that they come. That was very important. Thank you so much for that. Dr. Gayatri also would like to thank for your efforts. Dr. Indresh, you conducted the quiz, Mr. Cool. Thank you so much, and thank you so much for entertaining us also in the banquet. Dr. Sejal, I think you were amazing as an MC. You did a great job. In fact, some of the people were very impressed, and you may be getting more offers. And the shloka that you said in the beginning really impressed them, and they have begged me to somehow get it from you and share it with them. So please do that. That was a wonderful shloka that you said. Then I would like to thank Elizabeth for taking care of the student presentations at all different halls. I think we had. And also Dr. Vanishri for conducting the student section. Thank you for taking responsibility and conducting the entire student session. Thank you. I think I missed one person on the stage. I've been reminded of that. I apologize for that. That is Dr. Dhananjay. And I think I must appreciate the way you conducted the quiz. You brought in so much of life into the crowd and you interacted with them. Thank you so much. I hope you're not mistakenly on the stage. Yes, Dr. Lalita and Dr. Grishma, are they here? Yes. Special thanks to you all for working tirelessly with the scientific committee. I mean, the energy that you all brought in, the enthusiasm you brought in. Thank you. And even Grishma also. Both of you, thank you so much for all your efforts. I mean, you are running the show off the stage. So, I thank you all. Well, I kept the scientific committee chairman for the last. For the simple reason that scientific committee has been the most challenging committee. I mean, I must say it requires a lot of effort. So I first wanted to give it to somebody. They said, no, it's too tough, I can't do it. So I gave it to somebody else who halfway through said, no, I couldn't take it up, I have other commitments. Finally, I tried everybody, nobody was very willing to take the offer. I had no other choice but to give it to my wife. Profusely. She said, no way I can do it, I will not do it. But it took me 3 days of convincing her to take up this course. I think she did a good job. But once she took over the responsibility, she used to give me stress every day. Every day she would come and say, this is not done, this has to be done. And then she took charge of the scientific. And that's when my BP shot up after that. And then I was much more relaxed. I was giving the responsibility to others, but after that she started giving it to me. I think she did a good job and I appreciate that. Finally, to the alumni members who turned up from all across the country. I mean, they not only lectured, but they interacted. It was nice to catch up with all the old students, who are passed out. And we could rekindle and reignite the bonding with the alumni. That was I'd like to thank each one of them. Some of them are here. Personally, I would like to thank them. Next is, I think the most important component of the conference are the delegates. Delegates who have come from various institutions across the state and neighboring states. I thank them for their participation. I'm sure you would have had a wonderful experience. And then, of course, our own students. I think starting from the first year students, the maximum enthusiasm, maximum interest was shown by the first year. The first day when I went to the first year class and I asked them, how many would want to participate? I saw 90% of them lift their hand. And that, they have just 3-month-old babies in our institution. And that is the kind of enthusiasm they had. And I thank them for a participation. I'm sure you would have learned a lot because you are just entering the profession of dentistry. You are not into the clinical side, but you got an insight as to what dentistry is. How intricate dentistry is. I remember when I was a first year student, I attended a conference and that changed my perspective of the profession itself. That was a game changer for me. I hope it will be for you all also. So, thank you so much. There are a few very, very important people that I have missed. I've been reminded, so I would like to first thank Dr. Harshita and Dr. Karishma. Thank you for your contribution. I think the whole day today. I thank Dr. Krishna for the wonderful job you have done. And Dr. Harshita, who took complete charge of the valedictory function. Thank you so much. You are known for efficiency. Dr. Madhavi, reception committee. Thank you so much. But we missed you for the element and dinner. Thank you so much for being there. Dr. Ashmita, delegate. Oh yes. You're sitting way behind, I can't see. You should be sitting in the front. I mean, one thing about Dr. Smita is that she always very passionate. And when I asked her to get the delegate kits ready, she went to the university, spoke to everybody and got everything done. And I just asked her to get those folders and pens. She went and negotiated even a bag also. So, I mean, that's the kind of contribution she has done. Thank you so much. Making the delegates happy and giving you wonderful gifts. Dr. Satya Shri, how did I miss you? You worked with the certificate committee, you got all the certificates for everybody, the speakers, the delegates, the participants, and also the organizing committee. Thank you so much. Sorry I bothered you a lot with the corrections, but finally it's been worth it. Thank you. Dr. Akshata, she's here. She did a wonderful job with the mementos, and all those beautiful mementos which are given to all the speakers and all the resource person was personally designed, curated, and got done by Dr. Akshata. So I thank her for that. I hope I'm not missed anybody else. I'm coming to it, I just started. Baba Shankar is not to be seen. So much for all you have done for the conference in terms of your contribution and especially during the banquet. I think the staff, both male and female, very hats off to you. Dr. Ramya, thank you so much. Anybody else I have missed?
Gayatri ma'am, pedagogy.
Gayatri, yes, I've already thanked Dr. Gayatri, and I think Dr. Nirajita, yes. Thank you for all your support and all that you have done. I hope I've not missed anybody searching. I think I've covered all the staff. Anybody have missed out? Raise your hand. Dr. Vaishali, thank you. Thank you for all your support. I'm sorry I missed you because sitting way behind, I can't see you. Dr. Parimala, Shweta, Pushpalata. Yes, 3 people who are I think not here. I would like to thank them for their contribution. And anybody else? Parimula, can you stand up so that we can see you and appreciate your presence? Backbencher, you should be sitting in the front. Thank you. Dr. Rajnikant, I think part of the cadaver workshop. Thank you. And anybody else who have missed can raise your hand. Please raise your hand who have missed. Dr. Anita Sagarkar. How did I miss you? Thank you so much. But not only for your contribution, but making sure Roshan also contributed a lot. Supporting him so much. Allowing him to work late night and get things done. Thank you so much. Okay, I think I covered everybody. If I have missed out anybody, please raise your hand so that I acknowledge it. Right? Dr. Rohit, yes, he was the one interacting with the students for the banquet and of course for the workshop also. I thank Dr. Rohit also for that. Right, so I think I've covered all the stuff. If I missed anybody, it is not that, I have done it intentionally, but it has slipped my mind. So please excuse me. Right, so now I go to the second years. Second years, I mean, you are also good. You participated. I think 90% of you are here. I thank all of you for not only participating, but also helping us out with various activities. Third years, you raise your hand? Let me see how many of you are here. Good to see you all. I mean, my biggest challenge was to get you all into the system. I really appreciate that. 5 years has always been very cooperative, and I really want to thank them. Most enthusiastic. You did everything what I told you all. I really appreciate that. The interns. I mean, it's your show. I mean, you are the people who put the work. You made things happen. So thanks to all the interns who are the most busiest people during the conference, running around, organizing things, and getting things done. I mean, thank you so much for your support. It was your conference. DENTCON 23 is interns conference. So thank you all for that. And those wonderful volunteers, so many of them. If I have to name them, I have to make a big list. I want to thank all of them for their support. And Vyom, I mean, you were leading. So many of you. I mean, if I have to name few names. Sorry, it took just a couple of names which came in my mind. So I thank all of you all. And Rishabh, you were too good with the camera. Captured every moment of the event through his camera. Not only his camera, but directing the professional cameraman also how to take pictures. So I think he's done a great job. And I mean, the beauty about an event is that it has to be documented. Because we are in the era of NAC. So it was meticulously documented under the direction of Rishabh. I think it's been like a marriage in the family. Everybody contributed. It was 3 days of fun, frolic, academic, learning, enrichment, and everybody benefited from it. So I want to thank each one of you all. Then of course I have missed one group, the postgraduate students. Thank you for all the 9 specialities for participating in paper presentation and also as an organizing team. Thank you all. Really nice to see you all with the audience today. Thank you, and I hope I have not missed anybody. If you feel I have missed someone, you can always prompt me. I think we have covered everybody except the leadership of the institution. I want to thank, first of all, Honorable Chancellor, sir. He was so excited to be there, but unfortunately he couldn't make it because of his prior commitment and because of the mega event that was held just a day before, and it was quite a stressful event, so he had to be excused. So I want to thank him for supporting us, encouraging us, and I also want to thank Srinivas Murthy sir for encouraging us to do this event. And then of course Honorable Vice Chancellor sir, who was the main person why we conducted this event. Because he's the one, I wanted to do a smaller event. He said, no, think big, think global, think national level. And in the inaugural function he said, now think international. So I think the problem is the expectations are increasing, so now we have to think, we have to expand the scope of the conference next year probably at the international level. Then of course Professor Karmata sir, I mean he has been so helpful. I mean he's a man of a lot of experience in organizing events of this nature. His guidance and mentoring was very, very important. I thank them. And of course the Dean of the Medical College, she is so, I would say the whole team at the Medical College is so reciprocative. When I asked for the auditorium, they were so happy. When I asked for more number of halls, they gave it to us. Whatever we asked, they gave it to us. So really, I thank from the bottom of my heart Shalini, Dean of the Medical College, for providing all these facilities that you see around you in this auditorium and outside. And of course, Dr. Pratap, Dr. Hemant, the Registrar Sir, Dr. Venkatesh, and special thanks to Mr. Uday Shetty, the finance man. I mean, that was the biggest challenge to get the finance bills passed through. So he has been very, very cooperative, and I think you supported us. And he said, you go ahead and take care of all the expenses. Thank him also, the entire leadership of the university, and of course the non-teaching staff who were such an important component of organizing such an event. I thank each one of them, especially those people who are behind the housekeeping staff, who are responsible for cleaning up. who were actually the support staff. So I think these few words, I don't want to keep you holding for long. Thank you once again for making this wonderful and memory to cherish. So hopefully we will have a few more of these events going forward. So once again, thank you all. And thank you all for bearing us for the last 3 days. And hope you all enjoyed the event and hope to have many more of these events. Thank you.
Thank you, Dean Sir. You were the strength behind this DENTCON 2023. We all would like to appreciate your constant encouragement. Hoping to have many more national, international conferences under your guidance. Thank you, sir. I now call upon Dr. Karishma to continue the proceedings. Thank you.
Thank you, Dr. Harshita. Students, you have been so patient the last 3 days and listened to the various keynote speakers. It is now time for us to listen to you. To share the students' perspective of DENTCON 2023, I call upon our very own student, Vaishnavi from final year BDS.
Good afternoon, everyone. It is an honor to address this gathering of dental professionals at the conference DENTCON 2023. I'm thrilled to be here and thankful to be invited to share my experience and insights with you all. As dental professionals, we all are committed to promoting oral health and ensuring that our patients receive the best possible care. With advances in technology and new treatment options, it is more important than ever to stay informed about the latest trends and best practices in our field. The first day of DENTCON encompassed all of this. I myself participated in endodontics workshop and found that really interesting. As an undergraduate, root canal is something that can really send shivers down the spine. The workshop really helped me in allowing to think and enabled me to enjoy it. I hope all the students learned a lot as well in the other workshops conducted. Conferences like this provide us with the opportunity to learn from each other and share our knowledge and experience. We can collaborate to develop new ideas and strategies to improve patient outcome and advance the field of dentistry. The second and third days were power-packed, innovative and interesting topics were dealt in these 2 days. I was fortunate enough to even get a chance to present my poster and paper presentation in both the days. As a volunteer, I also had the chance to improve upon myself. I was able to manage teams, divide work, manage 4 years of undergraduate students, skills like teamwork, compassion, time management, and many more. I've learned a lot in these 3 days. I'm grateful for the opportunity to be here today and to contribute to the discussion. I hope each and every one of us has learned and earned a lot from knowledge to skills in this conference. I believe many more insights and discussions are yet to follow. All of this could not have been possible without you all. I would like to thank our beloved Dean Sir, all the dignitaries, the students, staff, my wonderful, wonderful teachers, and everyone who helped in making DENTCON a grand success. My sincere and heartfelt thanks to the organizing team, volunteers, and to everyone who was standing on toes for the event to happen in the best possible way. Thank you for such an enriching and wonderful conference. Thank you so much.
Thank you, Vaishnavi, for those kind words. Now it's the moment you guys have been waiting for, the announcement of all the winners for the scientific sessions. I request our Dean Sir to kindly present the certificate for the winners. For day 1, session 1, for the paper presentation, the first place is Dia and Taha. And in the second place, we have Sai Kalyan. Session 2, first place goes to Vyom and Vijay Lakshmi. Second place is for Dheeraj and Divya. Session 3, the first place goes to Agnivesh, Sukta and Abhidnya. And second place to Rupa and Ramya. We move on to the poster presentations. In session 1, the first place is to Anupama and Anjali. And second place goes to Harshita and Dheeraj. Session 2, we have a tie. The first place is Sanye and Rishabh and Ridhima. In second place, we have Nilangshi and Neha. Under the PG category, for the paper presentation in session 1, first place goes to Vismaya. And in the second place, we have Suraksha. Session 2, the first place goes to Dr. Anu Elsa Swarup, and the second place goes to Dr. Shreya and Dr. Aisha. And the second place is for Dr. Surabhi Chandra. Thank you, sir. I request Dr. Kavita ma'am to hand over the certificates for the day 2 winners. Under undergraduation category, for the paper presentation, session 1, the first place goes to Ms. Shreya Shagupta, Shivanand Patil and Sayantini. And second place goes to Ms. Nandita Shetty and Nidhi. Session 1 for poster presentation. First place goes to Dr. Jui and Dr. Jyotsna. Second place to Ms. Vaishnavi. Session 2, first place, Dr. Kushbu. Second place, Dr. Amit Tanshi and Akhila, Dr. Akhila. The winner is from MCOTS. Under PG category paper presentation, session 1, first place to Dr. Prasanna. And second place to Dr. Serene Joy and Dr. Neha. Session 2, first place goes to Dr. Jagriti. First place is for Dr. Jagriti from Maruti Dental College. The second place is for Dr. Pragna and Dr. Bharat. Session 3, first place is Dr. Asha. In second place, we have Dr. Pallavi and Dr. Nityashri. The poster presentation, session 1, first prize is for Dr. Gauri. And the second place is for Dr. Amreen, Dr. Shivani and Dr. Shikha. Thank you, ma'am. Request Dr. Sylvia, ma'am, to hand over the certificates to the winners of day 3. Under the UG category paper presentation, the first prize is Dr. Sheikh. Dr. Sheikh Rahman. And in the second place, we have Ms. Mahima and Ms. Kriti P. Session 2, the first place is Ms. Spandana and Ms. Suman. And in the second place, we have Mr. Faisal, Ms. Fatima, Mr. Dinesh, and Ms. Ishwari. Under the postgraduate category paper presentation, the first place goes to Dr. Shruti and Dr. Umu Salma. And the second place goes to Dr. Sagarika, Dr. Harshini, and Dr. Saraswati. We now have the winners of the pedagogy. The first place goes to Yukta. Second place goes to Sai Kalyan. And the third place goes to Vijay Lakshmi. Thank you, ma'am. I request Dr. Kranti sir to kindly give away the certificates for the quiz winners. In the first place, we have the OPGs. Can we have the whole team up, please? And the second place is a tie between the white and black. Team Black from the Anand Sagar. And Team White from Faculty of Dental Sciences. Thank you, sir. Congratulations to all the winners. And with this, we come to the close of DENTCON 2023. I request the organizing chairman, our dean, to declare the conference closed.
With gratitude to each one of you who are such an integral part of the conference, it's my honor and privilege to declare the conference closed. Thank you.
I thank you all for your time and efforts to make this mega event, DENTCON 2023, a grand success, and wishing for many more and bigger scientific events in the near future. I request you all to please rise for the national anthem.
अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे